to welcome our moderators for the first session, our president for the International Society of Plastic Regenerative Surgeons, Dr. Nelson Piccolo from Brazil. And I would like also to welcome Dr. Izdihar Fallata, consultant plastic surgeon in King Fahd General Hospital. Please welcome to the stage. This session will be about lower limb reconstruction and innovation in plastic surgery. Professor Hans Oliver Rennekamp, he's doing a workshop on the other side, but he will be coming and catching exactly his presentation as a second presentation. So I leave it to you right now, Dr. Nelson and Dr. Izdihar. Yeah.
All right, good morning. I would like to call Dr. Andrzej Piaczkowski. Sorry about that, Andrzej. And he's going to give us a master class about the innovations in plastic and robotic microsurgery.
Oh, thank you. Thank you very much. And thank you for attending this at this early time. So I'm going to talk about something that we're developing in Maastricht. It's robot for super microsurgery and what we are using it for. So we as a Maastricht University Center are part of the Microsure, which is a company based in Eindhoven. So what is the idea? We wanted to develop a super microsurgery robot in order to get superhuman precision with a really low setup, so that you can use your own microsurgical instruments that you don't have to buy stuff all the time that's really expensive, and that you can do it a hybrid, so that you can work from there and that you maybe can fly in or do online the operation. So this is the system that we have now. This is the generation 2. It's you see the handles where you wait. Okay, doesn't work. So you see there the handles where you take it in the hands, and these are the instruments. We are working now more than 10 years on that. It's somewhere about 12 years. And in 2015, we started with the feasibility studies, which is also published in PRS. And we looked then there if this is possible to do it, how is the time for anastomosis, is there anything happening if you do the anastomosis, and does the anastomosis work? So, and we evaluated this all with a SAM score. This is a score for evaluating how you do it. So this is obviously in a higher speed, the video, and you see this is all done with the robot. And here you see the difference. Left you see the hand, so you see the small movements of your hand, which we all can diminish a bit the more we learn. And on the right side you see the same person working with the robot. So you really see the difference between these two ways how to work, so that you don't have these small trillings. The thing is, you need to learn how to work with such a thing. So as you see in the beginning, it took a long time, 2 hours, to perform an anastomosis, and then it went down, because as you learn to work with it, you get faster. So then 2016 we published that on anastomosis in vivo in rats. And then we went on to do a clinical study. And what we thought would be really the ideal way to do it is lymphedema reconstruction. So we did this in breast cancer related lymphedema. We are a big center for breast cancer reconstruction, and at least 27% of breast cancer survivors develop some form of lymphedema, which is a chronic disease, and mostly is treated by manual lymph drainage and compression garment. The thing is, on the long term, this is not only a burden for the patient, but also for the health system, because patients get continuously this lymph drainages, and also the compression garment has to be given to the patient 1 or 2 years. So it's also a health economic aspect if you can improve that. So what are we doing? We are connecting lymph vessels to veins. So that's a lymphatic-venous anastomosis, and it's about 0.3 to 0.8 millimeter, this vessel. So we did a randomized controlled pilot study where we did this LVAs, and we validated this with a PROM and the arm volume. First of all, we did a mapping of the lymphatic vessels, and here you see a mapping with an ICG camera, and you can see there the vessel, and where it gets cloudy, the vessel stops. And so you can then mark on the hand the vessel itself and then go to surgery. We all do this on a local anesthesia. This is sort of the setup, how you sit there, patient is awake, and you just make a small incision on the hand. Here we have my colleagues. This is Dr. Q from our department. Here you see everything draped, the hand just lying there. Patient is lying there, and you can talk to them, it's not a big deal. And then first of all, you search for the lymphatic vessels. We have a microscope with ICG possibility, so you can also give some indocyanine green, and you can then see under the microscope the vessel. Here the robot is brought in, so you adjust the robot, it's all packed in sterile, and you can see there the ring that Tom van Mulken, he developed this robot over the last 10 years, and then you bring in the microscope, and then you can see her working. And this is actual footage of making the anastomosis of the lymphatic vessel to the vein with the use of the robots. So we had patient groups that were even distributed, and we had, as you see, the mean procedure time is the biggest thing. So if you do it manually at the moment, we need about 80 minutes for an anastomosis of a lymphatic vessel to a vein, and with a robot we still need about 2 hours for these 2 anastomoses. In the end, we looked at this, the disability score, and we didn't see a difference between the manual and the robot LVA. And if we looked at the volume, we saw a difference in the robot. So you saw that the index was lower, but in the end, it's not significant. So we don't know if we're doing there something wrong, or if there's really a difference. At least if you look at the daily use of compression garments, you see that the patients after 1 month already don't use a compression garment. After 12 months, it gets a bit higher again, but in the end, it stays really low. Here again, the photos I show you. This is the preoperative photo with the dermal black flow, this cloudy area. And there you can see, after the anastomosis, you can see really that the ICG is flowing into the vein. So then we published that as well. And then we had a small pause because we really wanted to get this robot into the market. So we first had to do a CE mark in 2019, and of course COVID hit, so we had a small pause in the development. And since 2021 we are starting back again now with digital nerve repair and with free flap studies. So we did a robot assisted free flap. I'll show you. Here it's a free ALT, and there's this installment again. You can see there now getting onto the vessels, and you can see here again this Dr. Q is sitting there and operating, and here you can see the anastomosis done, and this is the free flap completely done at ALT on the forefoot with the robots. This has also led to that other centers, just like the Uppsala Center in Sweden, took this over with Maria Mani, and they also use now this robot. And then, which I'm really proud of, because in about 2019, 2020, we did the first in-human free flap with a completely digital microscope. That means you're not looking at a microscope, but you're looking at a 3D screen, and you just have a camera instead of a microscope. We did a free flap there. We published that as well. And then we thought, okay, let's combine these two. So you have now, as you can see here, a 3D screen on the side. Everybody looks at the screen, and you're not looking through the microscope anymore, and you can sit on the robot. The positive thing about it for the development in the future is that you can sit anywhere. So the operator itself, and this is not only about thinking about maybe doing operations online somewhere else in the world, but also ergonomically. Because if you do free flaps, I don't know if you can relate to that. Mostly you sit like this, or you sit like this in front of the microscope. And with this, you can put yourself in the most ergonomic position as you want, because you have to sit there for at least an hour. So that's when we went from start, and we have achieved now new funding for a new generation, and this is really what we think is going to take off. This is going to come in the first quarter of 2024, because we just raised 40 million for that. So this is going to be the new generation of the robot. I've already seen it. It's not working 100% now, but we're going to start working with it end of this year or January. So we're going to go further with the LVAs, and yeah, there are more studies coming. Thank you very much, and all of this couldn't have happened if we weren't such a good team working all together in every part of it. Thank you.
Thank you. Thank you, NJ. We'll leave the question to the end of the session. And we would like to welcome Prof. Oliver to present lower limb reconstruction using local original and free flap.
Thank you.
Yeah. This one? Yeah. Thank you. So good morning, everybody. So now you will see where you can use the robotics in your daily work, either on the local regional flaps maybe, or at the free flaps, because I think sometimes like the perforator preparation is also very meticulous. So it's not only the microsurgery with anastomosis or super anastomosis, but also in preparing the perforators. So my topic, which was given by Dr. Ziad, thank you for having me here with this topic, was lower limb reconstruction with local original and free flaps. So as yesterday, similar to what I said about hand surgery and defects in hand surgery, it's the same in the lower limb. You have to think, where's the defect? What actually do you have? So in general, you have to analyze the defect. Do you have hardware which is infected? What type of bacteria do you have? Do you have a biofilm? And of course, how is the vasculature of the lower limb, which is definitely worth looking at. So what we generally do in these patients, we do an angiogram and we consult the vascular surgeons whether they can improve the vasculature, the inflow into the lower limb. And in Germany, it's actually now in the guidelines for difficult to treat wounds and large wounds to consult the vascular surgeon before doing any procedure which for coverage of large defects. So I think this is a nice collaboration with the vascular surgeon. We'll see later on why this is so important. So if you look at the lower limb, it's coming from the groin, knee, anterior tibial, Achilles region, and the weight-bearing area of the foot. So, and I will start with the knee and going down to the weight-bearing. And again, as I said, analyze the vasculature, optimize if possible, and also consider AV loop if possible. So if there's only one vessel left to the foot, then I ask the vascular surgeons whether it's possible for them to put a loop down further below. And it's also nice to have the loop because it's much faster than doing the microanastomosis to a loop than to deep somewhere in the P3 region of the tibial artery. So reconstruction options for the knee region. It's free flaps, but it's also local medial hemigastrocnemius, and we've heard about that yesterday also. This is an option, and I will show you some case here with an exposed screw there, and so for this defect. I covered it with a hemigastrocnemius muscle plus a little split thickness skin graft, and you get a nice closure. And it's a very fast operation, especially if the patient is older or not so well being for anesthesia. So if the defect is larger, or if you have exposed hardware which cannot be taken out, then the free latissimus is a good option because it's just a big flap, large-sized flap to cover a defect, as in this gentleman, where we had to cover this huge defect over the knee. So we took the latissimus and anastomosis here, and you can see the defect. Actually, we first tried the ALT, you can see on the left side, but we failed with this one, and then we went on to the latissimus, because especially in patients which need their upper body for training or for stabilizing, I try to avoid the latissimus. So in these patients, when I know they are depending on the wheelchair, for example, then I try not to use the latissimus, but try to use the LTP. Anyway, so finally we got a closure here for this patient. So it's not the most difficult region, but the anterior tibial region is more demanding, I would say. And depending on the size of the defect, you have to choose your flap. So either a big flap as the latissimus or a medium-sized flap as the LTP, or local propeller flaps for small defects if you have exposed bone of the tibia. So again here, a little defect over the tibia exposed after removal of a carcinoma. And so for this defect, we did a propeller flap. We did a Doppler for the perforator, and then we designed this flap to cover the defect over the tibia. This is another propeller flap. Now the other one was 90 degrees shifted, and this one was 100 degree shifted. So here you have to prepare a little longer, a little more distance of the perforator. Otherwise, you'll torque the vessel, and so the 180 degree turning is sometimes a little more difficult, and so you have to be careful not to compromise your vessels with the perforator. For a larger defect, as in this gentleman, there you have to go for a free flap, and here you have to take out the hardware. You have to debride the wound, take out all the dead bone, and then this external fixator was placed, and then we did a free flap with the latissimus dorsi. And as I said, sometimes you have these large defects and just one vessel left, which is necessary for the foot. And in these cases, I worked together with the vascular surgeons to put a AV loop first, and you can see this in the upper. See here. So this is the loop actually, which is the anastomose to the tibial artery and the saphenous vein, and then you have a long loop, and you can place your latissimus wherever you like, because you have this long, nice loop, and it's not so difficult then anymore for the anastomosis. So maybe for this case you won't need the robotics, but so you can really do it also if you like with the loops, because it's such a big vessel now. And this is the coverage down left with the latissimus, and then split thickness over the muscle part. So question about single stage, where there's two-stage AV loops, and in my hands, what I do is I do the loop 1 week before the free flap transfer, because I like to start with the micro operation and not start with the loop first, and then after 2-3 hours start then with the free flap. But you can do it in one step, you can do it in 2 steps, as you like. A mentor of mine, his approach was, if the AV loop is immediately running, he did the free flap immediately, and if it was in doubt, then he had a 2-step procedure, waiting a week until he had a nice flow in the AV loop. But as I said, for me, I'll split it in 2, because it's just for practicability. It's easier than doing it the whole day from morning until night or whatsoever if you have a problem. Another case here for a big, large defect over the tibial artery, over the tibial bone. In this case, we used an AV loop, which was done first, and then we did a free myocutaneous latissimus dorsi and serratus muscle flap, as you can see here. This is the serratus part here, and this is the latissimus part, and they're all connected. Oh, well, this is one back. So this is connected via the thoracodorsal artery then, and we sutured this over the large defect. Again here, this is the knee area. This is the latissimus part, and over the tibia here, that's where I placed the serratus muscle flap. And in former times I used the serratus fascia, and now I'm using always the muscle, because I've seen in too many cases that the fascia alone dried off with the split thickness skin graft, so I'm using now with the muscle, and I have better results taking the muscle instead of the fascia of the serratus muscle. So if we go down to the Achilles and the ankle region, again, you have a couple of options. You can use a free flap, either ALTP or a medial sural artery flap, or free gracilis with the split thickness skin graft. But there are also other options which I like very much, which is the distally based sural artery flap or the lateral calcaneal artery flap, and I'll show you some cases where I used this flap together with my colleague, Dr. Al-Sheri, who was working 2 years with me as a fellow, and we were always doing one him, one me. So we were a great team there doing these types of flap, and you will see he was also stipendiate of your country here. So I'm very pleased that I had him for 2 years. So this is the classic defect, Achilles repair, breakdown of the wound, a couple of debridements until it's clean, and then it's a question how to close the defect. And with a couple of VACs, you may get some granulation tissue, but you will never get a good split thickness skin graft taken down there, which is functional at the end. So in these cases, we design a distally based sural flap. We Doppler the artery, which is lying adjacent to the sural nerve. So you take this sural flap together with the sural nerve as your guidance, and then you turn it around 180 degrees, and you can cover the defect nicely. Another defect here, more lateral, so you can play with this pedal where you want to have it. And then close the defect either medial, lateral, or over the Achilles tendon. So it's a very versatile flap to cover the defects around the ankle region. So, but sometimes, and this is described in literature, you may have venous congestion with this flap because you're cutting the vena saphenous pava, and so there is a reverse venous flow, and in the beginning you may see some venous congestion as seen on the right side, and in these cases I use the leeches to decongest this flap, and this helps sometimes. So you may get some breakdown sometime of the of this area with this which is congested, but the good thing is you will get like the crane flap principle. You may always get some tissue left over, and then you do a split thickness skin graft over the rest, or you transpose whatever is left from the flap over the difficult region and graft the rest with the split thickness skin graft. So this is, for me, around the ankle, the distally based sural flap is really a working horse here, because you can design it in any shape and very large, and you can close the defect over the dorsal of the lower limb with the split thickness skin graft if your flap is larger than what you can close by advancement. So this is another flap which we have recently used also for smaller defects, or if the lower limb is not useful for a sural artery flap. So we use this lateral calcaneal artery flap, and you can see there the vasculature is really stable, and you Doppler again, and then you design your flap over the artery, then you raise your flap, you swing it into the defect, and you have to cover, and that's the disadvantage. You have to cover the defect then with a split thickness skin graft. You cannot close it primarily So you have to tell the patient that there will be a secondary defect, and this may take some time on that until this is healed. But as seen here with these, here again, this is a defect, a small defect over the Achilles tendon, and then we took from the lateral side here, we took the calcaneal flap and swing it around on the artery and covered the defect here with the split thickness skin graft. So it's another nice little flap if you don't want to use the sural artery flap, or if and sometimes when there has been rigorous debridement over the Achilles tendon, then the perforator which connects the sural artery to the peroneal artery is gone, then this is the only option to cover your defect. Here again, this little, really small defect, and again we designed this calcaneal artery flap here, and then we swing it around over the defect and covered the donor site of the flap with the split thickness skin graft. So just another flap, now just coming from the local flap or distally based flap to free flaps for the Achilles and ankle region. So together with Professor Al-Harbi and his group, we looked at what sort of flaps can we use to make this a nice coverage, which is also good for the sliding of the Achilles tendon. And sometimes if you do Achilles tendon repair, the defect is much bigger, so you cannot use the local flaps anymore, and then you're stuck with the free flap. So in these cases, you can either use the ALTP as a free flap or the medial sural artery perforator flap. And Professor Al-Harbi published actually this paper on reconstruction of the lower limb defects with the medial sural artery perforator flap, and it's a little meticulous, the preparation there for this flap, and therefore he determined it is aesthetics worth the effort. And we think, and that was our conclusion, that if you see this right picture, I think it's worth the effort preparing this nice flap from the dorsum of the lower limb to cover the defect. You can see here another medial sural artery perforator flap. This was a melanoma taken out, and further dissection. We had this large defect, and then we had made a sural artery perforator flap. Disadvantage of all these free flaps that they are asensate, and this patient, he was using his shoe without looking at his ankle, so he got this little chronic wound there. The good thing with these free flaps, in comparison, for example, to a skin graft, this will heal because it's a full thickness skin with underlying fat, so it will heal at the end, so I was not worried about this defect. Here again, we have done, in one foot we have done an ALTP, the other foot a medial sural artery perforator flap. You can see they both work for these type of defects here on the forefoot. If you design it nicely, and if you take down the fat in the first place, then after debridement, this is an option which you can use also for coverage. So for the medial sural artery flap, what we do is we scan the vessels, and what I use is this V-Scan Air from GE, which is a portable Doppler ultrasound. You can see there on the iPad up there in the corner. Where's my, here? You have your iPad, which is connected to your handheld Doppler here, and then you can exactly mark where your perforator is coming out to map on the MSEP flap here, the medial sural artery flap, because with the old handheld, sometimes they're so good that you Doppler some deep arteries in the muscle, and then you open up and you won't find anything. So this is now the way which I go with this V-Scan Air to really mark my perforators, either for the perforator flaps or for the free flap prior to harvesting the flap. And you can see there on the right upper corner is harvesting the MZAP flap, which is sometimes a little meticulous and difficult. But if the vessel is there, you can prepare it up until the diversion from the popliteal artery. And I used this MZAP in this case for coverage of this defect in the forefoot area with exposed bone joint, which was infected at that time. So I debrided it down and then put the flap here. And after the swelling will go down. It will be nice, good contour, and very stable situation at the end. So weight-bearing area, very difficult because it's a different type of skin. And the classic flap for the weight-bearing area is the instep flap on the medial plantar artery. As you can see, the vessel situation down on the left lower corner. Debrided a little more than what you can see up there. And then the flap is harvested and swung back into the proximal region, and then the donor site is grafted with a particular skin graft. Similar case, the flap is harvested and then insetted in the defect, and the defect, as seen here, is then covered with a skin graft because it's a non-weight-bearing area, and this is where you can put the skin graft, and the flap in the weight-bearing area here will give you a nice, good coverage. The last case here, and again, instep flap raised and then insetted here to cover this defect so that this patient could wear a shoe again. So, in summary, how I do it is analyze the defect, and especially, as I said, analyze the vasculature in limb reconstruction. We always do an angio-TC, or if not possible, angio-MRI. Then we try to optimize the arterial inflow. We consult vascular surgery, do an interventional AV loop if possible or if necessary. Then we choose the flap according to the vasculature and the defect size. And post-op care is important, as I said. You have to look after your flap, whether congested or not. So Doppler controls. But the only thing I do is DVT prophylaxis. I do not add any aspirin or heparin, and especially for the free flaps, in case revise if in doubt. Thank you very much.
Thank you, Prof, for this very informative presentation, and we'll leave the discussion to the end of the session. Now I would like to welcome Salma Al-Kutbi to present wound care through plasma device.
Assalamu alaikum. My name is Dr. Salma Al-Kitbi. I work in Sharjah, United Arab Emirates, under plastic surgery, regenerative, hyperbaric. And wound care. Our hospital is the largest hospital in EHS in Sharjah, and you are more than welcome to visit my small unit. I'll be talking today about basics of wound. I'll be discussing the wound healing cycle and how understanding the wound healing cycle will help us in our decision making and treating wounds. So initially, wounds are common. They are very common, 3 in 1,000. Chronic wounds are even more common. They are divided into 3 groups, mostly diabetic foot, pressure ulcer, venous leg ulcer, and they are defined as wound that has to fail 30% in 4 weeks. So what is wound? It's a break in the integrity of skin or tissue with associated disruption of structure and function. A wound classified according to the timeline into acute or chronic and to the causative factor, external and internal, or according to the depth. So wound healing cycle. Wound has 4 distinct stages of wound healing cycle. They are overlapping. They start with the injury with hemostasis to stop bleeding. So injury stimulate the clot formation. Clot formation, fibroblast, the blood clotting factor stimulate the neutrophils and macrophages to come into the wound. Then they start the phagocytosis and they release the cytokines to attract fibroblast, where the regeneration starts to occur after debriding and cleaning the wound, and then final stage will be remodeling. Usually a healthy wound will heal in 6 to 12 weeks, but concerning causative factor that might delay wound healing, there is a hypothesis that 4 major reasons causing delayed wound healing: local tissue hypoxia, bacterial bioburden and chronic inflammation, repetitive ischemia, reperfusion injury, and altered body response. So local tissue hypoxia. Initially, we all thought that oxygen is mandatory for the initial inflammatory phase of wound healing and respiratory burst, but now with evidence, oxygen is needed in all phases of tissue healing, and all wounds are considered hypoxic unless proven otherwise. Oxygen is needed as well for the redox signaling, and the redox signaling is the whole process manipulating the healing process. So it's oxygen dependent, and it's an integral component of the healing cascade, and signaling by reactive oxygen species, including nitric oxide and hydrogen peroxide, and it involves chemical modification of the target signaling protein. So this is the redox signaling, and it starts from the first phase of wound healing, that's with platelet aggregation and clot formation. It works through the inflammatory phase with the compacting the microorganism, go through proliferation with angiogenesis and cell proliferation until we reach a wound closure. Possible causes of wound hypoxia goes into microangiopathy, macroangiopathy, venous disease related to edema, and biofilm and wound infection. So chronic inflammation. There are several causes which lead to chronic inflammation. That is local tissue hypoxia, repetitive trauma, and trauma can be from the patient and it can be from the nurses, physician doing multiple debridements, aggressive handling of the wound, heavy bacterial bioburden, unhealthy devitalized tissue, and impaired cellular and systemic host response. Chronic inflammation is characterized by the presence of neutrophils as a pathological hallmark. It's characterized also by increased production of proteases with subsequent degradation of growth factors and overproduction of pro-inflammatory cytokines, leading to increased production of metallic metalloproteases. That is destruction of extracellular matrix. ischemia reperfusion injury, and this is biochemical and cellular event happen at the cellular level. So when the blood supply is cut to the area, there is a local inflammatory response that is exacerbated and spread by the reperfusion injury. And repeated reperfusion injury can lead to complete destruction of the vasculature and no reflow phenomena. So altered body response. This is mostly happened because of chronic comorbidities, steroids use, diabetes, poor nutritional status, cigarette smoking, mostly host factor. Age-related factor, which reduce actually the function and the amount of cell present for healing. So we understand this. We had a quick overview about the wound healing cycle. We'll talk a little bit about plasma. Plasma is the fourth state of matter. It is ionized gas, and it's present 95% in the universe, like the sun, like lightning, fluorescent light. So it's there, and people didn't know that it existed. And how it's created or generated through ionizing gas, putting too much energy in gas. So our cold plasma, and I have been using plasma for almost 1 year. Officially, it's in my hospital from December 2022. We have started trial in May 2022, and it is actually, it's a gas with free electrons, ions, electromagnetic field, visible ultraviolet light, infrared light, as reactive oxygen species. So what happened is that theory says that the plasma work in two ways. The lesser way is the electromagnetic field, which actually stimulates wound healing, and through the reactive oxygen species, which control the redox signaling. And what happened is that when you use the plasma bin over your wound, basically the reactive oxygen species, they diffuse into the upper part of the wound, which is called the micro environment of the wound, and modulate the redox signaling, enhance the redox signaling. So you are affecting the all phases of wound healing, plus the disinfectant effect of plasma bin. And this is why we found it very effective in our cases and practices. So this is only nice pictures from different references to support its role in disinfection, proliferation, angiogenesis, cell migration. My cases. So this is a patient which I always call him my failure in medicine. I've been treating this patient for the last 3 years. He's only 53 years old, with major depression, psychosis, inflicted self-harm. Why I feel that I failed with this patient? Because I was judgmental. You cannot judge your patient. I was telling him, you don't stop smoking. You always ignore the way you sleep. You don't eat well. So he disappears sometime for a long time, coming up with very bad wounds. For the last 3 years, we have healed wound, a reoccurring wound. Now he has 7 wounds. And this is the first picture there. He came from home after disappearing for 1 month with this wound. We had debridement by surgical done. This is done 7 September, the first one. Down is after 10 days. This is after 15 days, and this is on Monday only. Other pictures, the wound picture is changing very fast. We are using plasma bin twice a week for him. We're using antimicrobial dressing. We opted for a simple antimicrobial. If you are interested in knowing the dressing, we can discuss them later. See, we are still treating this guy. I don't know if we are gonna manage to heal him or we'll end in amputation, but for now, he is happy with us. He is not in, his depression is controlled, so we wish him luck. This is another patient who was treated by the general surgery department, and actually being a separate department, Sometimes we don't get referral for all the cases we have. And this man was already offered amputation. The nurse in the picture, he told him, don't go for amputation before discussing to the wound care team. We are all, in wound care team, we have 2 doctors. We are all certified from Canada and 3 nurses. And he came to us. We started plasma beam therapy. That is a long treatment, 3 times a week. Each session, 45 minutes. We used another antimicrobial twice a day. That is not available, as I heard, not available still in Saudi Arabia, but mostly coming soon. Actimars gel. After 2 weeks, they did debridement. He was referred to the plastic surgeon. Another debridement, and he had his skin graft done on 14 September. He's fine. And unfortunately, he filled out the day he was discharged from hospital, and some of his skin graft opened. He's still with us with the plastic surgery because they refused to give him back to us, but he's doing very well. Alhamdulillah. They are all recent cases. This woman came to us to emergency department, and they called me. She has abdominoplasty with infection, and the surgery was done in August in Turkey. She came, she got admitted. We did TDS dressing with Actimaris, alternate day plasma therapy, and 10 days, plastic surgeon, they took her, they did debridement, closure. We continue with therapy post-operative, and alhamdulillah, she is doing very well. So 2 weeks treatment, alhamdulillah. This is another patient who was operated in another hospital. He came to us self-referred for treatment. This guy is taking plasma therapy 3 times a week, and the next week, inshallah, we are doing 4D scan printing for him, inshallah. So this is another indication for plasma therapy in our hospital. Preparing wound for advanced therapy. 4D skin printing is very expensive, like 1 kit is 4,000 dirham. Plus that it takes time taking patient for abdominoplasty, this liposuction, and preparing the dressing. It takes time. So we just want to make sure that we succeed in our application. So we do plasma therapy before and after application of the 4D skin printing until we achieve healing. This guy is progressing very well, inshallah. If anybody interested to see final picture, I will leave them with Khawla once we are done. This is another case with 4D skin printing, treated by my coworker. He's 38 years old male, no comorbidity except that he is morbidly obese. General surgery, they did debridement of carbuncle on 10th September. We took him on 15th September for plasma therapy, and on this picture is actually on 2nd October, not 2nd September. Then next day we did plasma bin and 4D skin grafting. And this is him. He's progressing very well. We are using plasma to disinfect the wound and enhance our success rate. This is another patient. Actually, this is a patient that I catched him in the corridor. He was crying because he was offered amputation of his big toe. And I stopped because his daughter is stuck with us in the hospital. We did the plasma therapy for him 3 times a week with antimicrobial initially, and then we started the treatment with extracellular matrix. That's another dressing that is coming recently to Saudi Arabia, I heard. And he's fine. His daughter was very happy. And actually, we laughed at the surgeon who said amputation. This is another patient who's 88 years old, who suffered from panic attacks and from delirium attacks.
You have 2 minutes.
Okay, I will go quickly on my cases. So basically, we use the plasma bin to disinfect the wound to make sure that we have a successful application. Single application, AB Protect, patient discharged home and wound healed. This is another patient where we couldn't achieve magic with him because he's a busy person. He's 25 years old, only in university, but his wound progressing. We accept him every 2 weeks, plasma bin, single dressing every 2 weeks until he has healed. This is a patient who had amputation done in Germany. 75 years old, local male, diabetic. They are both in the same foot. The upper wound healed in 1 month. The lower wound healed in 3 months. I think because of the dynamic cerebral ischemia reperfusion injury related to stepping on the foot. This is a child who referred to from the pediatric surgeon with maceration of peristomal wound. And in 3 days of therapy, the child was discharged, and I will be seeing her, inshallah, on Tuesday. This is another patient operated by vascular surgeon, plasma band therapy given twice a week. On 26 June, he was discharged. He's a farmer living 150 kilometers away from our hospital. So every week he will come, take 1 plasma therapy session. He will use endoform and extracellular matrix because the wound was clean. Basically, we wanted to enhance granulation tissue, the proliferative phase. And we are almost done. That is only like few days ago, the last picture. And I'm done. Any question about plasma or wound healing?
Thank you, Salma, but we'll leave the discussion and the question to the end of the session.
Okay.
Thank you. Our fourth speaker is Dr. Wajdi Nasser. He will talk about peripheral nerve surgery in foot and lower limb.
Good morning. All right. Hi, everyone, and I hope you guys enjoying the lovely weather that's happening nowadays in Jeddah. Welcome to everyone from abroad. Away from a little bit gooey wounds and plastic surgery, actual reconstructive surgery, we're talking about the other fellows here, which is the nerve part of the lower extremity. And probably this is what would be the most debatable topic that has been discussed in the last 15 years. The plastic surgeons actually started upper extremity nerve surgery with the carpal tunnel, and some a little bit nasty fellows in the last 20 years started talking about the lower extremity nerve surgery, that if we can do the upper, why we're not doing the lower. So without further ado, I'll jump just to the topic. We are going to talk about the new hope for painful diabetic neuropathy. Many of the patients that are complaining of diabetes have a chance of 20 to 25% to develop lower extremity painful diabetic neuropathy. As you guys know, these patients are really stubborn, coming to your office, requesting all kind of narcotics, Lyrica, blah, blah, blah. I'm having pain, help me. So that's a new hope. A lot of people don't believe that. And I'll just talk a little bit in brief here. I know I have this topic has been discussed in hours, and I only have now 14 minutes. I'll try to make it as quick as possible. So as you guys know, and all of us know, that painful diabetic neuropathy, what's the medical literature is that it's irreversible. It's mostly palliative management. There is nothing much that you can add. Sometimes you give supplementation. Sometimes you give, the anti-neuroleptic medications to control the pain and to control the condition. Our colleagues in physical therapy may help with the nerve gliding, but that's it. And I would just speak about, the spread of this condition in the Middle East, and particularly in Saudi Arabia. As we are in Saudi Arabia, we have over 7 million people in Saudi Arabia with diabetes, and this percentage is not yet proved, but this is, hypothetically, we're speaking about that percentage. About 15% of those 7 million will develop ulcer because of neuropathy. Neuropathy causing ulcer is not the low arterial supply. What causing the healing of the wounds to heal is their arterial condition. And these are the factors that causing, leading to the amputation, diabetes, poor glycemic control, sometimes meal preferences, and of course the mortality of below knee or above knee amputation. It's all coming around peripheral neuropathy, angiopathy, presence of ulcer, peripheral vascular disease, and the consequences to be devastating. So this is a cross-section of a peripheral nerve in patient with diabetes, and you can see here the nerve fiber. I hope I can pinpoint, with the mouse here, or if I have a laser point. Looks like I can't. But it shows in the upper picture the normal nerve fiber under electrical microscope. And if you go downstairs there, increase the nerve fiber or the vacuoles, which means there is some sort of pathology that's going on. In Jacobson journal, they evaluated that in '78, and they just prove it. Diabetic nerve fibers have enlarged cross-sectional area, is more susceptible to injury than the non-diabetic patients. And that's raised a concern. What can we do? Again, the nerve vacuole or the nerve fibers increases, and especially in the small tunnels that we all know. In '85, the big gurus in plastic surgery in the US, Lee Dellon and Susan McCannon, just proved that is just, chronic nerve compression causing demyelination. And to some extent in my practice, that is true. That you have the 50% increase in diameter, eventually it leads to pinching of the nerve. So what happened with Lee Dellon? Lee Dellon is one of the famous plastic surgeons in the US, and he's a peripheral nerve surgeon. Actually, in his practice, many of his patients, they were happy about the achievement and the outcome in their hands with carpal tunnel. He just did, the medial carpal tunnel release, the medial nerve decompression, and the patients are happy. Then they come back to him in his office, and they're asking him, "Hey, doc, if you can't fix my hand, why you can't fix my feet?" And it sounds legit to him, at that time. Yeah, why not? But before he jumped into that principle, he just started a very lovely experiment in Johns Hopkins, where he made a few rats in the lab diabetic. And by doing that, he started to dissect their sciatic nerve in the lower extremity. And what he found that most of these rats with diabetes have cross nerve fiber, large sectional nerve fiber. In addition, their gait was monitored and it was disturbed. So he came with all the analysis about it, the ischemic factor, the vasonervorum on the nerve fiber, the microcirculation at that nerves because of the enlarged cross-section of the nerve, leading to pinching of the nerve and then eventually demyelination. So I don't know how did he do it and decompress, most of these rats' nerve in the lower extremity. But eventually, after he decompressed it and he made the tarsal tunnel release, I don't know how exactly the tibial nerve in the rat looks like, but he observed their gait prior, during their high glycemic status, and post. And eventually, he found out that their gait improved tremendously. So he jumped and started doing it in the real patient. And patient loved it, and many of his fellows start to follow him. But this did not come without a price. It still is like many debatable among many medical aspects, especially our colleague in neurology. You are taking diabetic patients and you open their feet, and you know what's the consequences that might happen. I'll come here just quickly and talk about evaluation. The most standard evaluation in the office is the Sims-Weinstein's, but is it really that specific to use the 5.07 monofilament with 95 grams of pressure, would that really tell you the exact story? Because many of these patients developing calluses and hard skin in their feet, which is really hard to tell if the patient really don't feel because of the neuropathy or because if they have a thick skin. A NASA institute came with a new device called the pressure-specified sensory test device. It's a 2-point discrimination that they believe it's more objective. We have one device here in Saudi Arabia. And unfortunately, it's not approved, at least, by many medical institutions. But they are improving the device year after year to become more objective in order to tell the patients, and in order to tell whether the patient have a true neuropathy or it's just something in the skin, like the small nerve fiber disease. So this is the device, the pressure-specified sensory test device. And it shows bars on the second half with the 2-point discrimination, which is believed by the beta fiber is more in charge of giving more objective neuropathic status. Nerve conduction studies. Do you believe in nerve conduction studies? We all know in the lower extremity is less than 50% specificity. Unfortunately, many factors that may disturb, the outcome, especially skin temperature and the technician factor when they put their electrode downstairs. It's like you having a spotter in the helicopter and you just spot the light and you don't really see the other fellows around. So I'll come just to the surgical aspect. It's a pretty much easy, straightforward surgical technique. You decompress the common peroneal nerve, you decompress the tibial nerve, and this is what initially Lee Dillon described it in the late 70s. You come here to, I don't know if this is, I don't have a laser point, but this is basically on the left, it's the common peroneal, on the right, at the tarsal tunnel. And if you can see here, in this section here with the common peroneal nerve, that you barely see the vasonervorum from the compression distally. And after decompression, you can see some part of that vasonervorum, which tells you really there is some sort of compression or macro compression in that nerve. And distally for the tibial nerve as well, but to be cautious with the neurovascular status, especially the tibial artery and tibial vein. All right, so let's come to a little bit of a debate here. You see all these names: Dillon, Wayman, Cafe, Esmond, Wood, Zhang in China made a very big study on decompression in distal extremities. But still, the medical community could not accept the fact to take a diabetic patient and open their feet. The challenges, they were believing this is a surgeon bias. The surgeon wants to do a surgery. The surgeon would like, to make business out of it. There's no prospective studies. It wasn't blinded, not controlled, and the complications that may, encounter. So they've been opposing it until a brave plastic surgeon, his name is Shai Rosen, he came, he's from University of Texas in Dallas, and he said, and this guy is interesting. This guy has no interest at all in lower extremity. He is really big guy of reconstructive cosmesis, face job, and all that kind of stuff. But he just said, I can fix that debate. He asked all the colleagues from different departments. They said, come on, let's fix. You wanted it blinded, you wanted controlled, you wanted. Let's fill all those criteria. And when he did, is actually get the approval from the IRB to make 2-group category to test, to do the experience or to do the test on the nerve decompression on those patients. Basically, he made the surgical group patients that actually having the surgical decompression, and guess what the other group is? Sham procedure, where they were basically just putting an incision and they close it. He made some inclusion and exclusion criteria, but this is what he did. He made a true surgical group and a non-surgical group, which is a sham, a straight sham procedure. The patient doesn't know, the surgeon doesn't know. The surgeon comes in the morning, he sees the patient, he opens the envelope, they tell him, okay, you do to this patient true surgery, and he comes to the next patient and you do sham surgery. And And interestingly, what he found that both groups, the surgical leg and the sham leg group, improved to some extent in the first year post-op. But is that the true case in the next 3 years? So this is actually like 56 months follow-up, which is about 4 years. And it shows that the data analysis support that tremendous improvement of the surgical nerve group decompression in the last 3 years of follow-up, unlike the sham surgery group. And this is a chart review that shows in the 4 years, in the first year, there is no really significant difference between the two groups, but in the following 3 years, the actual surgical decompressive group improved markedly. So Shai Rosen and Lee Dillon and many other people in the past, they put a certain criteria to do this procedure. Of course, not every diabetic patient with painful diabetic neuropathy can do that. They stated the major clinical factor, which is the positive Tenel sign. As long as you have a Tenel on the medial nerve, you can have the you can have the tibial nerve or common peroneal nerve with Tenel sign, and that would just lead you to more possible favorable outcome. So they asked him in the last conference in Chicago for Shai Rosen, is there a rule for surgery in the treatment of selected patient with diabetic peripheral neuropathy with possible superimposed nerve compression? And he stated in November 2015, absolutely yes. And this guy has no interest in lower extremity nerve at all. So, and this is his clinical trial. This is the link of his study. Of course, until now, it hasn't yet published. They are struggling with the New England Journal of Medicine to publish that, but still in the clinical trial.gov. I'll come to the last topic here, and if you allow me to give me 2 minutes, it's just I'm talking about the foot drops and nerve transfer, as this is a new technique that we came upon with Dr. Eric Williams in Baltimore, Maryland, where we started to do adjunct procedure for many foot drop cases. Instead of just decompressing the common peroneal nerve, we can do something more. So basically, I had an American truck driver post-motor vehicle accident and lumbar arthrodesis 19 years ago with a foot drop. We checked the anterior muscle group. We did not rely on the nerve conduction studies by itself. I usually do the examination by myself in the office. So in addition to the nerve conduction studies and EMG, I do pre-op nerve stimulation and I do diagnostic block. What's the goal of doing diagnostic block is just to do the vasodilatory effect of lidocaine on the common peroneal nerve, where it vasodilate and give me more blood flow to the nerve, which may indicate there is some sort of compression at the common peroneal nerve. So basically, I don't know if I can. This is a video here, but probably I can't get it. Do you know how to play it? Oh, someone jump in here. Cool.
Here with drop
Oh,
foot,
that's
we just
magical.
marked the line here. Anterior tibial
basically,
muscles
all
in
what
this
you have to do is
location,
just to have a 10
with
unit
the
device in your
common peroneal nerve
office. You
location
can
with
get
the
one of these
needles there.
needle puncture, these Chinese
patient to
needle.
move his foot. Can
You
you move?
locate it in 2 different areas, and you
Very
start
low
twitching it.
movement up, just
Patient
to the
actually
right.
cannot move his foot when I ask him to move. But when I
Here with drop foot.
started turning on that device by myself in the office, and he started to move his foot, which tells me there's something that I still can work on these patients. Of course, I'm having here dorsiflexion with no eversion, which tells me the superficial peroneal nerve might be involved in that condition. So I decided to take the patient and jump him to the surgery. I did decompression of the common peroneal nerve with internal neurolysis under the surgical microscope. And then we are using a very strong check nerve checkpoint nerve stimulator to locate the nerve, the deep peroneal nerve, where the injury is. So I did it here before decompression, and there is absolutely no motion at all, even in the nerve distally.
A window in the
So-
deep peroneal nerve.
We made a
We're
window in
going
the
to
deep
attach
peroneal
this
nerve.
nerve
I wish if I
to
had
this
a
here
pointer
right
to
here.
point
Okay.
exactly where we doing this. And we made a conduit. We just take a motor nerve branch from the tibial nerve, from the soleus nerve,
So we're seeing there.
and we
movement.
starting stimulating
the
it,
transfer
and
nerve.
boom, eventually the
See it?
patients start
How
to
strong
move.
is that? Look.
After 19 years, which is
See it?
in the medical
point
literature,
to the
this
foot
is
a little
out
bit
of the
as well?
golden period of doing nerve transfer cases.
Yeah.
And this is done in California. I did this at the Mercy Hospital in Bakersfield, California. And it's like,
Nurse.
this is about 3 weeks after the surgery.
Your foot, please. Oh, perfecto. Barely no movement up, just to the right. Go. Mm-hmm.
And that's pretty much it. I'm sorry for the extra 3
Your foot, please.
minutes. Appreciate it.
Thank you, Dr. Nasser and Nasir. Sorry. And can I have Dr. Khalid Khushaim, who will present oncological reconstruction lower limb?
السلام عليكم. طيب في البداية أحب أشكر الدكتور زياد الحربي على تنظيم المؤتمر الجميل والرائع، وعلى الدعوة والاستضافة بنتكلم في المؤتمر. So I'm gonna talk basically about actually a very interesting and complicated topic, which is post-traumatic oncological lower limb reconstruction. I tried to divide the presentation into 2 parts. يمكن أغلب I'm gonna talk mostly about the post-traumatic part, as we have been working a lot since 2018, my period when I was working in the European Hospital Georges Pompidou. under the Department of Professor Lauren Lantieri. And as we were a trauma center, actually, we had a lot of cases, combined cases with the orthopedic team on almost daily basis. I wanted to talk, to give a brief discussion, as there is in the literature, actually, when I tried to dig deep and deep, since I was a senior resident and then a fellow and an attending physician, about the data, the concept, the actual expertise and the decisions. As in trauma cases, we have a lot of gray zone areas. So basically, in the beginning, I wanted to give a brief a presentation about the complexity actually of the lower limb reconstruction after trauma cases. Treatment of open fractures and exposed bones sometimes can be very challenging after trauma. And the paradigms have been changing over the past 2 decades based on new concepts, such as the VAC, who came and changed a little bit of the paradigm and the timings, the timing of interfering, delaying sometimes the reconstruction. The OR logistics, which is a very actually important point, a practical point, because sometimes we don't have a 24/7 operating room to do microsurgical reconstruction. So the timing and shift, the timing was actually one of the most important question, one of the most important debatable questions. When to interfere, when to do the free flap, when to delay the free flap. Does the patient really need a free flap, or we can basically manage the patient conservatively? So, and it came also in the time between where there was a shift actually towards mostly the faciocutaneous flaps versus the muscular flaps. There's many challenges in the lower limb reconstruction, as we all know. I wanted just to give a brief, introduction, especially for the residents and senior residents and the fellows. Actually, the challenges are too many. I tried to put the most common challenges what we see in the lower limb reconstruction: the distal circulation, calcifications, extension of the soft tissue trauma, how to select the recipient vessels, and how to determine the pedicle length that we're going to choose for our free flap, and the positioning of the flap. All of these questions, sometimes some of these questions might sound a little bit, sometimes we take it for granted, but it's very, very important actually to plan especially the microvascular reconstruction procedures. General considerations. One of the most important things to begin with is the debridement with clear margins. Actually, we have seen a lot of cases that has been done, not in our center, but referred patients with flaps, local flaps, or free flaps on a non really good. Nice vascularized edges of the wound. I think that the debridement and getting a clear margin is very important in the flap survival. Reconstruction ladder is very important, but we have sometimes to consider the elevator approach. which we need to understand what do we need really to from our reconstruction. Do we need bone? Is there any bone missing? Is any muscle missing? Is any dead space that we need to fill? Reconstruction innovator approach has given the best functional results, and very important to evaluate the whole patient, not only the wound. And this is a lot of these a pitfall that we see is that we focus on the wound instead of evaluating the whole patient. We need to really examine the patient. We need to palpate all the 3 axes of the patient, vascular pedicles. We need to see if there's an infection of the wound, the depth, the size of the defect that we're going to cover. And then not forgetting the comorbidities of the patient and the smoking issues. If we can, but sometimes in the trauma cases we cannot really adapt these things, but in chronic wounds we can. One thing I have learned that teamwork is very important in microvascular planning. As doing daily free flaps or weekly free flaps is very tiring for the team. We used always to be 2 surgeons, 2 attending physicians, especially for free flap, for the free flap procedures, when an attending physician actually can harvest the flap and the other physician can prepare the recipient vessels. And this actually minimizes a lot the operating time, and it plays a very crucial part in in having a successful outcomes, delaying the operative time, and even delaying the in-hospital stay time. Economic flap harvesting, actually what we mean by that is actually in the planning, we need to plan, do we need a longer pedicle? Is the recipient vessels is superficial and exposed? If we don't need a long pedicle, sometimes it might benefit, we might get an advantage of not harvesting a long pedicle if we don't need it for preserving the donor part. One of the most steps before considering a microvascular reconstruction is, of course, the vascular supply. A CT angio is always the gold standard, with a possible, if we can have a 3D reconstruction, just in case if we want to. Actually, it helps in 2 things, 2 important decisions. First of all, is to determine the 3-axis permeability, the posterior tibial, anterior tibial, and the peroneal. And of course, giving us a clue if we were considering harvesting a lower limb free flap, such as the ALT, which we can see the perforators from the circumflex in the scan. Maybe a small note. I know not all the hospitals have, but the duplex scan, different from the Doppler, where we can see the quality and the flow of vessels, sometimes can help in harvesting the free flaps. The indications for further vascular workup might vary from previous history of trauma, bone fixations, if the patient had any comorbidities such as PVD, DM, and if there was any previous vascular injuries. But usually a CT angio is enough. So when we talk about reconstruction, about open fractures, actually this was described since 1983. We want to ensure the vascularized bedding and stable tissue coverage. This will aid us to reduce bacterial load, facilitates bone healing, and allow bony reinterventions when required. Extensive debridement is always the key, and a lot of lower limb reconstructive surgeons have always as agreed that even the onset or the timing of extensive debridement is sometimes might be even important than the time of coverage. So really debridement and extensive debridement of the wound is a cornerstone. And this leads us actually to a big contradiction sometimes. When do we need to put a VAC, when we don't need to put a VAC? We have to understand that the VAC is not a debrider. It doesn't replace surgical debridement, but it can help a lot, and it's a time saver, as we always call it, to prepare the wound for the reconstruction. It helps diminish the edema and optimizes the wound environment for the reconstruction. Antibiotics has been debatable. I'm not going to talk a lot about it because there has been many protocols in the literature. How many days do we use them after the closure of the wounds? And obviously they tend to reduce infections by a good rate. Now this drives us also to a very important issue that we all face as reconstructive surgeons, as plastic reconstructive surgeons, lower limb surgeons, is that when do we salvage and when do we amputate the limb? I have looked in the literature actually, but there has been no strict guidelines, and even the guidelines that we all agree about, the absolute versus the gray zone. In the gray zone criteria, we consider amputations in the tibial nerve if the tibial nerve was divided, plus extensive muscle loss, plus more than 2 compartments, and ischemia time more than 4 hours. But actually, what about if the tibial nerve was disrupted? Disruptions, if it was neuropraxia, it might take a lot of time to heal. And the problem is that we have seen a lot of patients coming years after the reconstruction, reconstruction, and actually there has been no data about these patients who wanted actually or seeked amputation, although the leg was functional, but the sensation was not there because basically they couldn't feel their legs and they seeked actually amputation. I am focusing in this talk about the class 3B. Basically, we're talking about fracture with extensive soft tissue loss, periosteal stripping, and bone damage with massive contamination. When do we stabilize? When do we cover the wounds, and when do we wait? There has been three. Actually, I would say 3 categories or 3 zones. The first zone is that to fix and flap immediately on fresh wounds. This has been described by Gabal in 1983 and has shown, obviously, it has shown very good union rates and less infection rates. The problem with this time frame is that we cannot see the demarcation of non-vital tissues. So sometimes we do cover the area, but 2 weeks later we discover that there is more stripping and there is more necrosis.
2 minutes, Dr. Hussein. 2 minutes.
Okay. I will go very fast. And this absolutely this method requires a 24/7 operative availabilities, OR availabilities. Versus the early reconstruction less than 3 days, also has been shown fresh wound. It's still a fresh wound, less bacterial invasion with no biofilms, but also the demarcation is now vitally of non-vital tissue is missing. In reconstruction, superior to from 4 to 6 weeks, has been shown that there is, yes, we have a well-demarcated wound, but the wound actually turns in a chronic wound. Scarring, infection, and osteomyelitis might also be present. In the immediate, that is in between 2 to 4 weeks. I think 2 weeks is when we reach 4 weeks, we have maximization of the scar tissue, and we need wider excisions. The treatment options: defect size, location, local donors, blood vessel size. The algorithm, I'm gonna skip. Actually, this is very important. Sometimes in lower reconstruction, big trauma cases, I always say that we usually prefer the posterior tibial artery because it is actually deep between the muscles, and in most of the trauma cases, the posterior tibial artery is not injured or not macerated, comparing to the anterior tibial artery, which is facing the interosseous membrane, and in a lot of cases can be strapped. The thing is, the most important point here is sometimes we have a stump, and when we have a stump, actually we need to consider going more proximal in the anastomosis, because in either ways, the stump, you're not going to use, the artery is occluded, so it's very important to think about using the stump. And this is what we have been talking about this case. This was a trauma case, lower extremity case that I did an LD flap. And this is where I wanted to say that sometimes we need to go maybe in this, actually here, we can see that we went a little bit proximal to use the stump of the posterior tibial artery to affect our anastomosis. This is actually a classic. It's very classical on the anterior surface of the anterior medial surface of the lower third of the lower limb. A patient had a trauma. Fixation was done by plates and screws by the orthopedic team. 2 weeks they fixed under tension, and there was a wound necrosis and exposition of the plates. ALT is a very good option in these cases. Even 2 weeks after the trauma, we had some difficulties in the perfusion, in the inflammation and dissecting the vessels, but it can be done if the vessels are permeable. Surely we can reconstruct without delaying, because the more we delay these patients, the more they tend to go into osteomyelitis and other chronic problems of their lower limb. This is the 3B reconstruction of Gacillo 3B. Orthopedic team, in such massive cases like this, what we do is the tissue coverage. Sometimes we do. It's very difficult to sometimes to do to make the anastomosis or reconstruction with the use of external fixators, and this is one actually of the cases where we have I've done an ALT to reconstruct the exposed bones, and fixation was done by a place and screw, a clue in the tibial clue by the orthopedic team. The last thing is I'm just going to talk very quickly about this study. We have been discussing. It has been discussed in Brussels. The aim of there has been no prospective or retrospective cases in immediate reconstruction after sarcoma resection in cases which included a major vessel. And as we know, as reconstructive surgeons, in big cases when we have a major vessel involved, we cannot leave the wound open. We need to basically reconstruct the area, having or being sure that we have a zero. Our margins are negative. We had. It was true that we had a high rate of complications, but complications we have to wait. To wait and between immediate complications versus I would say the later outcome and the limb salvage. So all the immediate complications were actually not that significant, not that of a problem. It was dealt with. We had no vascular, arterial or venous thrombosis. Complications were lymphocele, hematomas, the venous graft. We had one case where the venous graft was thrombosed, but we had no flap failure. So we were trying just to say, and now we have included, it was 8 patients, and now we have included, at the end of the study, we included 40 patients. All the complications were early, but it's a very feasible and reproducible technique, satisfying vascular graft patency, despite the high rate of postoperative complications. Thank you very much.
Thank you, Dr. Hushaim. The last presentation in this session will be about ChatGPT by Dr. Fahad Al-Jandan.
Good morning, everyone. I would like to thank the organizing committee, headed by Dr. Ziad Al-Harbi, for giving me this opportunity to present today and for this amazing opportunity to gather with diverse group of surgeons who are very talented. Today, I will talk about a very specific topic. It's about the use of generative AI in plastic surgery. We want to find out together whether it's a friend or a foe. There is no conflict of interest to declare. This is the same topic. It got accepted recently in PRS journal and will be published this month. So I'll be talking about the brief introduction on ChatGPT-4 in plastic surgery, some clinical applications related to plastics, the use of ChatGPT in medical education, research, patient education, and finally, we'll talk about some challenges and ethical considerations. So what is ChatGPT-4? It's an AI tool that was developed by OpenAI. It was developed by Sam Altman and his colleagues in San Francisco. It's basically an AI tool that understands and generates text. How does it differ from other AI tools or chats? It's trained to generate responses that make sense in context, unlike the other traditional chat platforms, like the ones we use in the banking apps or the communication apps. So it gives responses in context, as if you were chatting with a human being. So how does it differ from earlier versions like the ChatGPT 3.5? It's better than earlier versions, and it's more creative, and it can be used in many different fields. So how do we use it? There are two simple ways. You can either log into the OpenAI and register an account, or you can use other platforms that can give you access, like the POE, or the Platform for Open Exploration. This app is available in iOS. Other websites that are worth looking at is the Chat PDF, where you can upload PDF files and you can chat with the AI about the PDF contents and ask it to summarize it and give you the important points. There are other apps like the Hugging Face and other similar apps. So how can we use it? One of the potentials of the ChatGPT-4 is it can be integrated into medical applications like the ones we use in the hospitals. For example, the track care through what's called an API. An API is an application programming interface. It's basically like an Uber or, let us say, a waiter. So he will take your prompts or the orders and take them to the application and get back to you with the request. So how can we use it in a clinical, what are the clinical applications that we can utilize it in? We can use it in writing progress notes and discharge summaries. For example, this is a typical note written for an abdominoplasty patient. As you can see, it's written in an unorganized way. Just all the information is listed, like the patient's day 1 post-abdominoplasty, her vitals, her examination, and the plan. So what we can do, we can ask ChatGPT to write it in a soap manners, and he will write it in a very organized way. As you can see here in this example, you can see it organized the same information in a very nice way, subjective, objective, then the abdominal assessment, the clinical examination, drain output, and then the plan. Also, you can utilize the same principle in the operative note. For example, if you have a patient with a trigger finger, you can ask the ChatGPT and give it a prompt to write an operative note for your patient. You can give him the variables. For example, if you have specific preferences for like the type of anesthesia, the suture material, and then it can generate a very nice operative note, and you can modify it according to your preferences. Also, in writing surgical consent, you can write a consent for a patient, for example, who will be undergoing a bilateral reduction mammoplasty. So it can generate that consent with the full name. You can give it the variables, and it can do it for you. And then you can modify it according to your personal preferences. As you can see here, the personal information, then the procedure was listed. And then the common risk and complications, you can also ask it to write it with the percentages, and the benefits, alternatives, and then finally the patient's signature and your signature as well. Another useful application is that it can help you with generating on-call schedules. For example, let us take this example. We have Lamis, Mohammed, and Hattan. They will be doing calls for the month of June. We can ask ChatGPT to generate an on-call schedule that includes the 3 equally, and we can specify, for example, that Lamis will be on leave on the 2nd week, and it will give it for you in a few seconds. Another useful application is that ChatGPT can be utilized as a virtual health assistant for patients. For example, if a patient has like a question, instead of using the traditional apps, this app can give very updated and very useful answers to the common questions that or inquiries that the patient might have. But be aware that you have to keep in mind that ChatGPT-4 is still work in progress and has limitations. So it should not be relied upon as a sole source of information, especially in medical consultations. To summarize, ChatGPT-4 helps in streamlining medical documentation, improving operative notes, creating surgical consent forms, optimizing on-call schedules, enhancing consultation reports, and assisting in medical consultations. Then we'll move on to the next application, which is the use of ChatGPT-4 in research. ChatGPT-4 has been explored in research and academic writing. It can generate case reports quickly, but with citation concerns. Sometimes it hallucinates and it can give false citations. However, it can create abstracts that are often mistaken for human work. It identifies novel systematic review ideas in plastic surgery. And however, it's limited to idea generation, not full systematic reviews. And human expertise is still essential for data interpretation and best practices. This is an example. This is an article that was published by Gupta, and here they explored the potential use of ChatGPT-4 in generating systematic review ideas. And impressively, it gave like 10 ideas, novel ideas for systematic reviews. Like, for example, the use of robotic technology in cosmetic plastic surgery, the effectiveness of non-surgical fat reduction treatments compared to liposuction surgery, and so on. If you want to use it for like medical citations and references, I would recommend using Perplexity, which is another generative AI model that was developed by Meta. It's more precise in terms of providing accurate citations when it's compared to ChatGPT-4. The third application is the use of ChatGPT-4 in medical education. ChatGPT-4 can act as a virtual tutor, answering questions and providing explanations on various plastic surgery topics, procedures, and techniques. This helps students gain better understanding of the subject matter and clarify any doubts. For example, a student, what is the difference between a skin graft and a skin flap? ChatGPT-4 skin graft is a piece of skin taken from one area of the body, while a flap is taken with its blood supply. So this is just a brief, simple example. Case-based learning, ChatGPT-4 can generate detailed case scenarios and high-quality exam questions to help students apply their knowledge in practical context. This involves analyzing a patient's condition, selecting the appropriate procedures, and discussing potential complications and outcomes. Additionally, it can assist with preparation for USMLE and in-service exams. This is a study that was published, and it concluded that ChatGPT-4 was able to pass the 3 steps of USMLE exams with excellence. And when compared to ChatGPT, the earlier version, which is the 3.5, ChatGPT-4 did much better in service exams. And this difference was statistically significant. Sorry. This is a study that I published recently, and I explored the use of ChatGPT-4 in the Saudi medical licensing exams, and I wanted to explore the accuracy of it in performing the exams. And surprisingly and impressively, it scored very high in all fields, including obstetrics, gynecology, pediatric surgery, and medicine. The highest score, got 96%, was in obstetrics and gynecology. And also we published another study. It was accepted in PRS. It will be published soon. We gave ChatGPT-4 50 questions from a board review book, the plastic surgery oral prep book. And it performed very impressively in all fields, in all questions, the 50 questions. And we scored the performance using 4 parameters, including accuracy, clarity, completeness, and conciseness. And it scored very high in all parameters. Let us take an example. For example, here I'm a plastic surgery resident, and sometimes you have to give him a code. You have to pre-code the ChatGPT-4 in order for it to perform very effectively. So you have to tell him that you are an expert in the field of plastic surgery. Please write for me a clinical scenario to test my knowledge. So he gave this scenario. A 45-year-old patient presents with severe facial burns. After a fire accident, she has lost significant portion of the skin and soft tissue of the face. How would you approach her reconstructive surgery. I know this is a very simplified example, but you can have a better example than this. For procedure simulations, ChatGPT-4 can guide students through virtual simulations of plastic surgery procedures, outlining the surgical steps and explaining the rationale behind each action. This can help students familiarize themselves with the procedures before performing them in real life. This is just another brief example. It's a simplified example about the student asked, can you give me a brief overview of the rhinoplasty procedure? Certainly, here's a summarized version of rhinoplasty procedure, and this is the steps. You can have a more detailed explanation, and it can walk you through the steps of the procedure in details. And also for preparing presentation, for topic selection, creating structured outlines, developing content, suggesting visual aids, providing citation assistance, offering presentation tips, and serving as a practice audience for feedback. However, it is essential for residents to verify the information provided by ChatGPT-4 with trusted sources and consult with mentors and colleagues for guidance. This is an example. Resident helped me create an outline for a presentation on facial reconstruction after Mohs surgery. Sure, here's a suggested outline. It will guide you through the outline, what to talk about and what to include in your presentation, like introduction to surgical techniques, case studies, post-operative care, and conclusion. Other uses of ChatGPT-4 in medical education, as I mentioned earlier, it can assist with research, professional development. It can give you assessment and feedback, and also it can help residents prepare personal statements, and also for you as attendings in preparing recommendation letters. Another useful application is the image generation. There are two, the most popular applications are the Midjourney and the DALL-E. This is also by OpenAI. So this is an example of utilizing the image generative AI. This was published in the Journal of Plastic Reconstructive Surgery. The question was, what could we make of AI in plastic surgery education? And this is an example where you can generate, these images are not true, just like mock images for exam purposes. Like you can ask the DALL-E or the Midjourney to generate a man with a defect on his face at the area of the jaw, or this lady with a lump on her arm, and then you can ask you can examine the residents or the trainees. In order to maintain the privacy of our patients, we can utilize this opportunity, this great application. This is another useful application where you can upload images and ask the ChatGPT to analyze the image. This is an example. I took this from the internet. They uploaded this image and they asked ChatGPT-4 to help them with interpreting this image, and the image was tinea. It's a fungal infection. This is the ChatGPT-4 answer. It's commonly referred to as ringworm or tinea corporis. It's characterized by red, itchy, circular rash. So it can help you with diagnosing certain dermatological conditions. I tried to apply it to play with X-rays, and I uploaded some X-rays from the internet. However, it disappointed me. It wasn't able to pick up the fractures in many scenarios. Sometimes it was able to pick it up, so in many other scenarios it failed big time.
Fahad, you have 1 minute.
Okay. So, and ChatGPT-4 in patient education, this is another application. It can create diverse educational content for plastic surgery patients in multiple formats, written documents, interactive features, personalized content. It's more engaging and dynamic compared to the conventional resources. You can also customize pamphlet and educational material with individual requirements and interest. This was found to improve patient comprehension and supports well-informed choices. Like, for example, instead of giving the patient instructions and like post-rhinoplasty, you can give him interactive quizzes, like scenarios. If you have a swelling or like you have a nasal blockage after rhinoplasty, what would you do? And you give him like a multiple choice questions, and then he will answer it, and then it will direct him to the right answer, and this way the information will be fixed in his mindset. For example, an interactive quiz for a patient who underwent an open rhinoplasty. However, we have to keep in mind that there are some ethical considerations in ChatGPT-4 used for plastics and reconstructive surgery. The accuracy and reliability and potential errors can provide also outdated information. Hallucinations, as I mentioned earlier, leading to incorrect or fabricated answers, especially with citations. Biases present in the training data set, because this application was designed in the USA, so it might be biased and can give you false information. There are privacy concerns, especially if you want to upload patient information. This can raise privacy issues, cost and accessibility for healthcare providers, and uncertainty in adoption among plastic surgeons. And finally, important, we have to address these challenges to ensure safe and ethical implementation. So the take-home message, ChatGPT-4's ability to reshape plastic and reconstructive surgery can help with advanced surgical preparation, customize patient learning, accelerate research. However, we have to keep in mind the necessity of considering ethical concerns and restrictions, utilizing ChatGPT-4 responsibly to enhance patient outcomes and care. So is it a friend or a foe? Definitely a friend. However, we have to keep in mind that it's complementing human expertise and not replacing medical professionals. Thank you.
Thank you, Fahad. For the sake of time, we'll have a coffee break and we'll be back in 11 exactly to start the second session. Thank you.
Hello. Hello. So welcome to the session. It's a pleasure to start this session now. And we are just going to start right away with our first speaker, Professor Nelson Piccolo, on a keynote lecture on fat grafting in burn and complex wounds. Thank you.
Oh, here. I guess I need my glasses. How does it go from here to, oh, it's there. I thought I had first ask ChatGPT to do that for me. Thank you so much. I'm very happy to be here. It's really a privilege and an honor to be invited and to be able to share with you some of our experience with fat grafting. As I mentioned, yes, I've been doing this for 13 years now, and I'm really very enthusiastic. The more we do, the more enthusiastic we are. And I'm going to try, in this 20 minutes I was given to talk about this, some of the basic stuff that we do in scars and wounds. We saw some of it yesterday, and some of the new things we've been doing, the recent things we've been doing, and some tricks we learned along the way to make other procedures easier. So as I mentioned, we're a family that we have this burn center in the center of Brazil, and we do see a rather large amount of patients every year, and using fat grafting has completely changed our practice in the sense that we now know when we see a wound that what we can do with it in relation to the time course and what's going to be. It's going to heal by itself. It's going to need a flap. It's going to need a skin graft. Pretty much it has become part of our everyday routine. And of course, there's multiple advantages to using fat grafting, mostly the ability of the cells to differentiate into different tissues and the growth factors present there. But as I said, yes, I think one of the main advantages, at least what impresses me most, is the decrease in fibrosis. Wounds in the past that would have a huge hypertrophy, and we have been taking care of these patients for ages. Even if we get fibrosis, you can go back with fat grafting, do it again, and then you release the fibrosis or the retraction. Back home, we sort of like we coined some different terms. Not that we coined them. We use different terms in relation to what we're doing. So when we mention fat grafting, of course, it's something that we're going to inject inside the tissue, and we use a retrograde injection. Fat delivery is very frequent to us to receive huge infected hematomas from the public hospital. There's a lot of motorcycle accidents in my town. As the economy got better, people who used to ride the bus start buying motorcycles, but they really don't know and don't respect all the traffic laws. In a regular day, you may see up to 8, 10 adults with accidents like this in the OR. And of course, lipofilling. We do our most common, my personal most common aesthetic procedure is the regeneration of the female genitalia. So we use the Coleman technique, and we have been doing so for the past 13 years. We haven't changed it. And basically, if we have a scar, we're going to plan to be able to undercover it, everything. So we go through a 19-gauge needle and the pink needle, and we go with the cannula, the 1.8 millimeters. Usually the standard cannula is a 7 millimeter long cannula with one single side port, and we'll try to do retrograde injections all under the scar or the wound that we're actually taking care of. We also do fat delivery, and most frequently we use the dermal roller, you know, depending on the thickness of the scar, up to 2.5 millimeters. And we occasionally use the laser. The laser makes a hole, let us say, much more efficient and much more similar all over the wound. But we have I was discussing this over breakfast this morning. Our patients have a hard time accepting a new wound. The CO2 laser causes a wound that takes sometimes a good 8 to 10 days to heal. And even if you apply fat on top of it, as we're going to see it here, and some patients have a difficulty of accepting a new wound. You know, they have suffered enough during the time they were healing. And also for Brazilian standards, the use of laser is too expensive, and sometimes we cannot do them on government patients. So most usually we, nice, not everything is working. Oh, let's go back. Let's see what we can do here. Huh. I need help. Can somebody help me? But anyway, what we usually do, we do either the microneedling or the CO2 laser, and this will produce thousands of micro punctures, and then we deliver the fat, a centrifuge fat on top of it, like if it were an ointment. And we use a Vaseline gauze dressing with the Day2 solution, like a Curtex around embedded on Day2 solution. Day2 will destroy protein, but does not into fat. Let's see if the next video is going to work. And we do get a fair amount of number of patients with venous ulcers, and we inject fat under the wound, under the indurated area, that typical indurated area. These people have had these wounds usually for several years, and they have a very indurated area. So we we inject fat under that too, and when we microneedle that area, and we debride the wound, and we deposit the fat all over it. And in some patients, we have gained up to 3-4 centimeters circumference on the lower leg, so they feel much more comfortable in time, because of course these patients, they heal and they come back to us for repeated injections under the indurated area. So you release some of that tightness, and they feel much better in time with a more comfortable walk. We usually do the injection first, and we deposit the fat later. And when we talk about fat delivery, we're either thinking of a hematoma cavity or the cubiti, as we're going to see shortly. So this is typically what we have attained. This is an old picture. In those days, we were waiting something like 2 months to re-inject. Now, currently, we do from 4 to 6 weeks on scars. And the patient continues to use the pressure garment while he or she is being injected. This boy was a patient of ours, eventually healed, and he lives about 1,000 kilometers from us. He went home and he never wore his pressure garment. He came back to us 6 months later, and we did 2 injections in 5 months, and this was the result. So of course we are very impressed with this type of result, and this became a routine, taking care of patients who use pressure garment and do not have benefit with the pressure garment, or patients like this one that did not have an opportunity to use the pressure garment. This child was not a patient of ours. She came to us, it's a sort of complicated because there's a lot of different things, so I had these arrows there. You can see both Ella, the left side, she has a retraction. She has a retraction on the right medial canthus, on the left lateral canthus, and a retraction band on her neck. In here, we can see the changes that she did. This is only fat grafting. There was no surgery here. So I ask you to please take a moment and take a look mainly on her Ella, which is completely different. She no longer has the retraction when she smiles, and the left lateral canthus, the scar has gone away. Here you can see a little better that you can see the neck band has also disappeared, and she has no more retraction here, and her ala is round again. This is just fat grafting. So of course we now know that we can do and apply this procedure, and we know the results are going to come. This lady, same thing, she had a chemical peel at a local dermatologist, had severe retraction, and she recovered her ala anatomy and released her lip also with 2 fat grafting procedures. This lady was a patient of ours, and she developed this hypertrophy. This is 2 injections in 3 months. The result, 1 injection in 3 months for her lip, that's the result. And this is the result on her lips at 6 months. And most importantly, she had a severe retraction. She was unable to open her mouth, and we also injected periorally. And this is the result at 3 months, and this is at 3 months we can see her teeth. At 6 months we can see her teeth. So we know these results are cumulative, as I mentioned yesterday. This young boy came to us with 3 months after ethanol burn, and we did a scar resection. We injected on his was 2 sites that we injected, something like 0.6 cc's of centrifuge fat. And this is him at, I think this is at 5 weeks. His mother sent me, yes, 5 weeks. He sent me a picture, a phone picture. And we do this as routinely. This young girl had an ethanol burn 4 months ago, and she already had this much scar. She healed 4 months ago. She already had that scar. We resected the scar, maintaining the shape of the ear. And this is her results at 3 years later. And just recently she came to visit us. This is 7 years later. We absolutely no recurrence. So the result is really permanent. And we take the results is going to be permanent. And we tell the patient, if something changes, please come back to us. Like this gentleman, he has this keloid after shaving. It was an 8-year-old history, and we did several partial resections, intralesional, not going to the subcutaneous tissue. We did several of these and injected fat under the suture line, also trying to be intralesional or immediately sublesial. And we were able to get this most impressive result containing his keloid. This was a true keloid. This was shaving scar. And of course, he did improve, and we were really surprised that we were able to do that also with the keloid scar. This gentleman was a shooter. He was reloading ammunition. He blew his thumb and his 3rd finger. This was the appearance. He came to me after being partially treated at some other place. We removed the sutures, and we injected fat, and we delivered fat to the wound. And most surprisingly, this was the type of result he had. You can hardly see where the original wound was. So as I said, we have several reasons to be impressed with this. This lady, I think she was a motorcycle accident. I may have a crushing injury, yes. Ran over by a car. And she came to us, and we debrided 21 days after a crushing injury. She came from a public hospital. We debrided the wound. She had a cavity that we inject fat on the cavity and debrided also over the debrided wound. Then she was grafted. And as I showed you yesterday, she has absolutely no adherence to the deep tissue, not to the fascia, not to the flexor tendon or the tibialis anterior tendon. And this is really surprising, but yielding a great result. And that's usually the routine result that we get when we do that. This lady was ran by a car. The tire did this injury on her. We did 3 injections on her every 18 days. And this is the impression that we have 1 month after cure. She came to us, and these were her plantar impression. This is like a just wet foot on top of a paper towel. And you can see the left side, her longitudinal arch is very short, and that her foot doesn't even touch the ground. So we decided to go, we took x-rays that we're going to see here, and we did intra-articular injections. She had a severe fibrosis on the intra-articular Chopin and Lisfranc joint lines. And as you can see here, her left foot, which is on your right, on your left, has a very tall longitudinal arch, and as you go in, there's an improvement there, and you can see in the picture here compared to the right foot, Chopin line and Lisfranc line are obliterated by fibrosis. And after we did the 2 injections, 2 fat injections intra-articularly, she completely recovered the suture line, the joint lines is exactly the same as the right foot, going back to a normal plantar impression, the footprint. So she's now able to walk even a little better than her right side. She's now able to walk normally. This lady had a 7-year-old wound, venous ulcer, and we exactly did that same procedure. We debrided her. We did 3 fat graftings on her, I think, 2 fat graftings, and she was grafted. She healed in 52 days. This is the appearance, 8 months post healing. Her daughter keeps sending us pictures. This is 3 years, and this is 10 years. Absolutely no recurrence, no hypertrophy. As in time, we realized we could use fat in more than one way. So we decided maybe that, myself, about 1 in 5 of our patients is a child, younger than 4 years old. And of these, they are 40%, sometimes 35% of our major burns. And sometimes, very frequently, they'll have deep burns to the hand. They'll come and touch the oven. Brazilian homes have stoves that the oven is on the bottom, and the child comes and they have a glass so you can see what's inside. Very frequently, a child will touch the oven when it's very, very hot. It's a very frequent injury. And we would have to go in and incise and do grafting, and we're always concerned about finding the neurovascular bundle while we're cutting. So we decided that we would add fat and protect that, and also make a bed. Sometimes you'll see the tendon right there. So we decided if we added fat, we'd have a couple weeks before, we would have a more vascularized bed, and we would know for sure that we could cut the skin, and there would be two advantages. When we saw fat, we know it would be through the scar, and when we saw fat, we know we were above the neurovascular bundle. So we started doing this with children like this, hand retraction. We would do fat injection on him, a very small child. This one had 10 kilos and 200 grams. So we got 2.5 cc's of fat. We injected some under the scar. We microneedled and injected the rest on his hand. He did improve with the first injection, but not enough to be considered normal. So we went back in and we injected again. This was the result after the second injection. And when we cut, as you can see there, we can see that there's fat right there. Usually you don't have that much of fat there. Everyone that have done this procedure, you see the neurovascular bundle right away, and you see the tendon down there. So we went and we skin grafted from the calvus plantaris, which is a colorless skin. And this is the type of appearance immediately on the operating room. And this is result with colorless skin and completely normal hand. Even in more serious cases, we also can do that. This kid was severe burn on his hand, and we did the same thing with him. We grafted the third, fourth, and fifth proximal fingers, and we injected fat. That's the type of appearance when we brought him to the OR and opened the wounds and incised it. We used the same type of skin, and that's his result. So we now know that we can do this safely, in the sense that when you go back, you for sure have a more vascularized bed and a safer wound, that you don't have to worry about hitting the neurovascular bundle or even the tendon on the tip of the knife. And most recently, what we have been doing over the past year or so, we started working the ultrasound. We use ultrasound, as I mentioned yesterday, to help us, guide us in the major joints that we do frequent injections. And then we realized that you could use a more sensitive ultrasound. Now you have ultrasound that you can actually see the hair follicle. So we have a colleague that has this ultrasound, and we send the patient to her, and she will evaluate the patient preoperatively. So like here she describes, I'm sorry, it's in Portuguese, this is a line she sent me, the scar, the subcutaneous tissue, whatever the scar is, and this is the appearance of the lady. This lady, I treated her several times with a fat graft. She had a severe retraction on her left forearm, was not originally our patient, and we did a couple Z-plastics. She did okay, but as she grew, she developed a retraction band from the epicondyle to the base of the first ray, the scaphoid. So here you can see the arrows show, this is where the sensor is. So one part is over the scar, the other part is over the retraction band, and the other part is over just scar that we originally treated with fat grafting a long time ago. So you can see the thickness is completely different. Wherever on the left of the picture, the ultrasound picture, that's the subcutaneous tissue with scar, and the right is and where originally we placed fat grafting in the past. And on the right side, that's the subcutaneous tissue without the fat grafting. And this is you can see some of the Z-plastics there. And so we went in, and that's exactly where the band recurred. So we did several injections there. We used 36 cc's of fat, and then we used the microneedle, 2.5 millimeter microneedle, a derma roller. and to injure, in a sense, right over there. Then we deposit fat immediately. What happened here? Stop. Immediately on top, and then we decide to go also in the volar area there, added fat. This is the type of dressing we use, just Vaseline gauze with acrylics on top and Day2 solution. And this is what we get. This is 1 week after surgery, after fat grafting. This is what they call the power Doppler that we used to see, like the echocardiogram, you see blood flow, arterial flow, venous flow. And very surprisingly, there's a lot of new irrigation there. And you can even see a new
1 minute left.
A new artery. I have 2 cases to show. Thank you. You can even see a new artery there. And here you see the area that has the fat grafting, how thick it is, and the same area now it's post-operatively. The area that has the fat grafting, the new fat grafting, and the area that has no graft, there's completely different thickness. And if you look at the video, this is new vascularization. That's arterialized vascularization. That's new, wasn't there before. And this is what we're working on now, is try to quantify the amount of fat. I think by a couple months from now, I'll be able to say how much fat actually stayed there in the long run. But we definitely know there's much more irrigation there. And this is where the area on the retraction cord that she followed it, that we have irrigation, new irrigation, all area that was fat grafted. This is a patient that had a chemical burn, and we took care of him with fat grafting. And we took advantage of him being under anesthesia. He had a pes planus due to lack of proper shoes, so we decided to reshape his plantar area. And similarly on this case, this patient had several different volumes, on his left foot. And then to make sure that he would support his foot on the traditional first and fourth and heel, that he didn't have that. He had also sort of pes planus shape. And we were very surprised that on his left side, that's the thickness of fat that is there. And on the right side, DIR is right, ESQ is left. You can see the difference between his right foot and his left foot. And he's the doctor who sent us a map of the thickness of the areas that were fat grafted, so we can accompany in the future, of course, and compare how much fat was that. But most surprisingly, when you compare the left side that was injected and the right side that was not injected, you can see the humongous amount of new vascularization that's not even seen. It's the same machine, the same sensor, the same time. So you can see there's a lot of new vascularization on the left foot. And although we knew this, I personally didn't realize that it was so intense, that the vascularization of grafted areas. And we can now know, like, for example, this is 1 week post-graft on the left foot. This is the right foot, normal foot, nothing was done there. You cannot see anything with the power Doppler. This is 35 days. The new vessels are still there. And when you go to the right foot, same thing. You hardly see a blood flow there. So this is a new frontier for us. This is the center of Brazil. This is something that we consider most important, that we'll be able to do this. And as I said, I think we'll be able to quantify this. And very quickly, I'm going to talk about what we do to the cubiti. We used to do, I was trained in the US, general surgeons would do this, and they would do large random flaps and try to cover the wound, 3 weeks to the wall suction. And then we decided, I was doing this when I came back, and maybe 10 years ago, I decided that I would do not rotation flaps anymore, just advancement flaps after debriding. Dr. Salma showed a very good presentation saying the benefits of creating a new wound, debridement. So what we do, we make a new wound, so you can start from scratch. We debride very thoroughly the wound, and then we do like a hand test, we'll be able to advance. And we make a flap, and we suture several suture lines, and we add fat as we go with the suture lines. Every new suture line, we add fat, and we tie, and whatever fat is in extra, it's extruded, and will come out. So up to the last row, we keep adding fat, centrifuge fat. And this is the post-operative result, 3 days and 7 days. Of course, this person healed. I'm just trying to save time here. This is another case that I originally saw at another hospital. I debrided her. On this case, when you advance flaps, because it's very close to the end, or sometimes with advancement flap, you're going to close the intergluteal sulcus. So in this lady, she healed, we actually had to go back and put a small skin graft there so she could have the normal rotation of her gluteus, her buttocks. But most surprisingly, we have several cases like this. This is 34 by 22 centimeters wound, three times the debrided. This gentleman had a severe necrotizing fasciitis, a meningomyelocele patient, wheelchair-ridden. And then we think about how can we do an advancement flap? Well, you just do it partially. And this is being true. With the recurrences, of course, you don't have, for every 100 cases that we do, the sacral ulcers, maybe 6 or 7 will open, and you have to do it again. Ischial ulcers are more frequent because of the bone contamination. Up to 10% you have to do it again. It's a smaller wound, but you have to do. And of these 10, maybe 1 or 2, you're going to have to do a third time with severe bone debridement. So this is one lateral advancement flap on your left side, and one left advancement flap at 2-week intervals. On your right side, one more bilateral advancement flap. So every time you go back, you do exactly the same. It's a new wound. So you clean the wound, like if you're removing the cup from the water fountain, you're taking the first cup, you completely take the wound layer, you make a new wound again, you advance again with the same principle, sutures and fat grafting. It doesn't really matter the size of the wound, because every time you're going to have a new wound and you treat exactly the same way, and you're able to close a wound like that.
Please come to an end.
I'm finishing, thank you. These are 2 procedures at 2-week intervals and 1 procedure at 3-week intervals. Advancement flaps only, there was no rotation flap. And that's his closure, and he's been doing like so. This is like maybe 3-year case already. So what do we believe that fat grafting does in cavitary wounds? Like from my own experience, it completely changed our routine. It saves very expensive peripheral tissue that in the past we have to do rotations in our boards. The answer still is a VY flap. You definitely kill every other option. It's the answer you have to give when we take our boards. We don't use drains, no suction, wall suction anymore. And if you do have a recurrence, you do the same procedure again, exactly the same way. And we definitely, about fat grafting, we know it limits fibrosis while you're healing, decrease fibrosis after healing. The results are cumulative, and we usually get functional and aesthetic results. And as I said, scientists like you here will keep fueling the way we use fat. We practitioners of plastic surgery use fat on an everyday practice. I thank you very much for the opportunity. Please take a moment to look at this press and become a member. Thank you so much.
Okay, we're going to have Professor Palua presenting cases of perforated flaps for head and neck post-burns.
Thank you. Again, I would like to thank for the kind invitation. It's a great honor to me to attend this prestigious meeting here in this wonderful city and in this fantastic location. Congratulations again to the perfect organization here. Dear chairperson, dear colleagues, I'm just waiting. I had some problems with my presentation, but he was the person who saved me. No, it's, no, this is the wrong one. No. Oh, but it's not the... Whether... I can give this here now. Maybe. Yes. Unfortunately, it's not the shortened version, but I try to stay in time.
If you want to point, you can use the mouse point. Because
Thank you very much. Yeah. Well, head and neck reconstruction in 2005 became a hot topic when Dubernard et de Vauchel in France performed the first face transplantation. If face transplantation is a possible alternative for the future, just a fiction since then has been discussed controversially. However, long-term risk and outcome need to be evaluated, especially the immunosuppression has to be improved. As possible alternative to face transplantation, further development of autologous flaps, especially from the shoulder region, is an important topic. The history of regional flaps of the shoulder is a very old one. More than 180 years ago, the American surgeon Matte described a release of mentosternal contracture using a shoulder flap. In 1949, Kazanjian and Converse, and in 1958, Kirschbaum described some modification of these random pattern flaps. All these flaps had a restricted length and a high incidence of tip necrosis. The identification of the supraclavicular artery by Lamberti in 1979 encouraged me to perform an anatomical study on the vascular supply in the angiosome of the supraclavicular artery, and we found a constant pedicle consisting of a supraclavicular artery, 2 veins, and 2 to 3 nerves. The knowledge about the anatomy allowed us to use the former skin pedicled flap as a pedicled or free island flap. After more than 40 reconstructive procedures in Switzerland, we performed in this patient supraclavicular island flap. This is almost 30 years ago, and here the result 5 years after surgery. I published this technique in Plastic and Reconstructive Surgery Journal in 1997. To reduce visible scars at the neck, we further developed the technique by tunneling the supraclavicular island flap. In this patient, a squamous cell carcinoma was excised and temporarily covered with artificial skin. 25 years after radiation therapy, for cosmetic reason of beard here in the chin area, she developed this tumor. After the complete excision of the tumor was confirmed by the pathologist, we covered the defect with a tunneled supraclavicular island flap. And here, the result 1 year after surgery. And you can see that she has a free range of motion. Here, 10 years after surgery, 15 years after surgery. Here, the donor side after 15 years, and she presented, I don't have the pictures in this version, right a couple of months ago, now 25 years after surgery. Now the patient is 82 years old. Here, we published also this modification in the year 2000 in PRS. Besides the satisfactory results, we have some limitations. Flap size restricts use in full face reconstruction, flap thickness reduces facial expression, and in larger flaps, tension leads to scar formation at the donor side. To avoid these limitations and to get an ultra-thin supraclavicular island flap, we pre-expanded the donor side angiosome. This technique allows for full face reconstruction, provides optimal skin texture, color, and thickness, maintains facial expression. There is no need for microsurgery or prefabrication. Surgical procedure starts with implantation of the expander. Filling volumes vary between 300 and 1,500 cc's. Finally, the scar is resected and the defect covered by using the pre-expanded supraclavicular island flap, like in this patient with mentosternal contracture due to a keloid after burn injury. Here, the early result after 3 months before he went back to his home country. Also, this modification has been published in this here in PRS in 2005. A more recent development is the anterior supraclavicular artery perforator flap. Instead of the supraclavicular artery, an anterior supraclavicular pedicle is used. This artery emerges above the clavicle in the gap between the two bellies of the sternocleidomastoid muscle. The artery pierces the platysma, runs to the deltoideo-pectoral fossa. The artery is accompanied by one vein, and the flap is drained by a second vein to the external jugular vein. The ASAP skin island is placed into the deltoideo-pectoral fossa, anteromedial to the classic design of the supraclavicular island flap. Pre-expansion of the flap is possible. The extended size of the flap is with up to 35 centimeters in length and 12 centimeters in width. Primer closure of the donor site all the time is possible. The ASAP flap can also be used as a free flap. So I'm missing the free flap example. We performed this to the foot in a patient with melanoma. However, advantages compared to the original SIF, the tissue from the deltoid pectoral fossa is thinner, more pliable, and shows a better color match to the face. As you can see here in this young boy, we corrected it with a bilateral pre-expanded ultra-thin ASAP flap. Here from the frontal view and here from the side. And here is another patient also with the same. These are the early results in this patient. And here a patient with pediatric burn scars here in the face, also reconstructed with a bilateral ASAP flap, here intraoperative view. And here the result after 1.5 years, the right side, and here on the left side. Oh, now I have the patient with the free flap, sorry. Here the defect after excising the melanoma was covered with the free ASAP flap. Here the patient with the recipient and the donor side, and here our publication. Well, what can we do if the coverage of defect is not possible with a local or regional flap? A dermal replacement could be an alternative for head and neck reconstruction, for instance with Integra or alloderm. This young child with mentosternal adhesion, we then scar excision, then we covered the defect with Integra. After 3 weeks we removed the silicone sheet of Integra and we covered the neodermis with the skin graft. fixation of the skin graft was performed with VAC. To be honest, the preliminary result was pretty poor and disappointing, and after 1 year, the young boy developed a real scar recurrence, and so we decided to go ahead with the reconstruction. There was no facial cutaneous flap available for face and neck region locally, and so we decided to go for a regional flap, for instance, in this case for a trapezius flap. Here, the Doppler probe of the descending branch of the transverse cervical artery. We resected the scar. Here, we covered the defect with the pre-expanded trapezius flap, and here, the young boy 2 years after surgery. Free microsurgical flap can also be an alternative for a head and neck reconstruction. Well, advantages of free flaps are individual flap design, remote donor site in cancer reconstruction. Disadvantages, differences in color and texture, and of course the risk of thrombosis after microanastomosis. Here are some examples for flaps available for the reconstruction of the head and neck. Here, this is one case, it's a very old case. We reconstructed this young boy with a scapular flap, and here you can see the result 6 months after reconstruction. In this 82 years old patient, basal cell carcinoma was excised preauricularly. Then we covered the defect with a parascapular flap. Here you can see the intraoperative view. Microanastomosis was performed to the facial artery and vein. And here the coverage, and here the patients 2 years after the reconstruction. Well, but what can we do if the pedicle is involved in the scar, as in this patient here? You can see that the pedicle is in the scar area. We resolved the problem taking the pre-expanded flap from the contralateral side, and we reconstructed the bold area in the temporal area and preauricular area with a pre-expanded scalp flap. Here, the intraoperative view, and here the expander on the scalp. Here, the reconstruction of the hairline, and here the patients after the reconstruction. You can see that not only the hairline, but also the contour of the face has been reconstructed successfully. A very helpful modification of the ASAP flap is the osteocutaneous ASAP flap.
You have 1 minute.
Following long-term mechanical ventilation, the reconstruction of tracheocutaneous fistula can be a challenge. Here, a patient with persistent tracheal fistula after long-term ventilation. Here, the intraoperative Doppler probe. Harvesting the bone chip. This is a vascularized bone chip from the acromion or the clavicle. Tunneling the flap and closure of the defect with the vascularized bone chip. And here on the right side, the final result. The scars are not very visible after this procedure. Here the CT scan, and you can see the bone chip. Here our publication. Coming to the conclusion now, the ASAP flap provides thinner and more pliable tissue compared to the supraclavicular island flap, yields a sufficient amount of tissue for total facial reconstruction, gives excellent functional result with good sensitivity, optimal skin texture and color, ensure satisfying aesthetic outcomes. Primary closure of the donor site is all the time possible, and the closure of the tracheocutaneous fistula became possible. Thank you very much for your attention.
Thank you very much, and thank you for staying on time. So the next speaker, I'm happy to introduce Professor Hans-Oliver Rennekamp, and he's going to teach us about scar management technique using microneedling.
So again, thank you very much for being here. Again, I got the challenge here to talk about scar management techniques using microneedling. Actually, it's based on an article which we wrote for this book from Hayako Zoku and the other editors, where we talked about indication, rational scientific background, procedure, and some results. So there are a couple of options, and we have heard a lot of interesting ideas and various approaches to reconstruct scarred tissue. It's operations, as Norbert Palua alluded on. We have heard something about non-invasive treatments, fat injection, and I would like to talk about the medical needling as a procedure to improve scars. And it's basically these scars which are either extensive or where you have circumferential scarring, where you cannot place an expander when it's circumferential, the whole extremity, or the complete torso. So there we see an indication, and according to this diagnosis and assessment classification system of Ray Ogawa, with the broadband contractures and contractures with entire circumferences. That's where we see the clear indication for these techniques. Other techniques, and we will not talk about that, are acne scars, rosacea, and wrinkles can also be treated, and striae are also a nice indication for the medical needling, but this was not the topic for my presentation today. So historically, Orendreich described in 1994 the subcision technique for the scars, and that was combined with the technique by Cameron and Doucet, who said some needle dermabrasion with tattoo gun actually to improve the scars. And then Fernandez actually described this percutaneous collagen induction therapy with a needle roller. So this is the 2006 publication from Fernandez together with Aust, who was in our department there in Hanover, back in Hanover. And so the mechanism which was suggested was either was further triggers a healing response to rolling. Then the needles which go into the skin with a rolling device, they should actually do a subcision of the scar. And the technique is combined with in our hands with vitamin A and vitamin C transdermally. And now I've just learned from Nelson that you can combine it now with fat, and I will try that when I'm back home. At the moment we combine it with vitamin A and vitamin C. So Is this the right one? Yeah. So does it actually do something? So everybody is doing the needling, but can you prove that it really improves the collagen? And with this Mason Goldner trichome stain, you can actually stain the collagen. And in the right side of the picture, you can see the needling group 8 weeks after needling in this animal model. And you can see actually the improvement of collagen by the needling with this device. And the other effect of the needling is the thickening of the epidermis after needling, as seen in the right side as compared to control on the left side. So besides these histological changes, we can see physical changes in the skin. So besides the holes, and Nelson has already shown that we have holes in the skin, but we also increase the transepidermal water loss. So the skin has a sort of breakdown, and that this may increase the potential to deliver whatever you like through the normally closed skin down into deeper areas. And this is actually the way how we think that the vitamin A and the vitamin C is doing its job in the skin. So vitamin A, as everyone knows, antioxidant, anti-inflammatory. It modulates the extracellular matrix, and this is what we want in the skin as well. It stimulates collagen synthesis, stimulates angiogenesis, and is proliferative for keratinocytes. And we have the epidermal thickness here. So let's switch we got the switch in the presentation. Anyways, so the vitamin E actually has an effect on thickness, but together with the needling, you can see there's a much bigger improvement in the vitamin A. So what we do is we pre-treat the scar with the vitamin A. Then we needle, and we suggest the patient to go on with the vitamin A. The patient has to buy the ointment with the vitamin A, so sometimes they won't do this because they can't afford it. So that's the drawback in this scenario. But we suggest that he should use the vitamin A to improve the epidermal thickness in the skin or in the scar area. The vitamin C, similar antioxidant, anti-inflammatory, leads to epidermal differentiation, stimulates collagen synthesis again, and regulates dyspigmentation, which is an effect especially in the scar management. And I've learned from others that they combine actually the medical needling with platelet-rich plasma. And if you go to the literature, it is really proven that the platelet-rich plasma significantly improves the results of the needling. So if you have the chance of doing the platelet-rich plasma, I would suggest to combine the needling with the plasma, because it has really been proven in these two publications, especially the last one. It's a clear yes as a suggestion to use the platelet plasma in this systematic review. So the procedure itself, as I said, we do a pre-treatment with vitamin A and vitamin C solution. Then we do the operative treatment with a microneedling. This can be combined with an intraoperative PRP. And the post-operative care, as I said, we suggest vitamin A and vitamin C also. So we use the rollers, and there's a couple of rollers on the market. So the left type is the original one. The right type has some more needles and in a row, which is you have to be careful when you do this in the OR, so I'll show you why. And then you have the stem type device, which is probably a good option in the face because you can do it really meticulous, but you will not have the subcision effect of the rolling device with the stem type. So again here, we use for the scars, we use a 3mm needle device, because even with the 3mm needles, you will not get really the 3mm, but rather about 2 to 2.5. So that's why we use this device, and we call everything above 1mm, we call medical needling and not the cosmetic, which you can buy in the internet. So, and again, the idea behind the medical needling is that you puncture the skin and you do not abrade the complete epidermis. So the healing response is not an inflammatory response like if you take away the complete epidermis like with a CO2 ablative laser, but you make the punctural hole. So at best you can compare it to the fractional CO2 laser. And here's the histology from another publication where you actually can see these puncture holes. So it's not the complete wound healing response as if the complete epidermis is missing, but it's really these puncture holes which stimulate the new collagen synthesis, and where all the other applicants like the vitamin C, the vitamin A, the fat graft can penetrate deeper into the tissue. And so the procedure itself, you roll or puncture a couple of times in different directions, which is especially important if you use this right roller, because the needles are all in one row, and if you do it only in one direction, you will get like this rolling device pattern if you're not careful enough. So you have to actually do it in different directions so that this is an arbitrary pattern at the end. So here in the OR, under general anesthesia, so this scar is rolled then with this needling device, and this is how it should look like after your procedure. Here it's cleaned, post-needling, and then it's dressed either with the oil, with the vitamin A and C oil, and then some fatty gauze for the first 24 hours. Here's a clinical result of the burn scar, a gentleman with this scar, and then we did a needling 3 times at the end. We needled, and this is a comparison of how he came, and this is the end result after 3 needling sessions. And this is up pre-needling, and below it's post-needling with this after treating of these burn scars, and another pre and post needling. So but it's just pictures, and another one. So just to make it more scientific, Dr. Austi actually examined all these patients pre and post, just to evaluate also the patient satisfaction, because that's the most important part. Is the patient satisfied at the end with his results? And there's a clear yes, the patient were satisfied post-operative significantly with these results. And we have also done the POSA score, and it shows also a very, very significant improvement in this retrospect workup of the needling patients at the Hanover Clinic at that time. And here again, the satisfaction was really, really improved, and in the scars, but also in the wrinkles and other entities. So some limitations, some complications. We saw 2 infections in this series, which we did. In the face, we saw 2 herpes simplex infections after full face needling. We do see, if you use the 2 to 3 millimeter needlings, you have bruising for a week or more. And this is accomplished with the inflammatory response. But we do not see scarring, we do not see the hyperpigmentation after this procedure, and we did not see photosensitivity. So we recommend actually this as an adjunct in the scar therapy. So This anti-aging modality is also effective in scars and can modulate existing scars as shown in histologies. It does not induce scar, which is very important if the patient comes to you and asks why if it's a past history. And it's an inexpensive alternative to the fractional laser, which is a similar approach, but it's definitely a much more expensive device. Thank you very much.
Okay, we'd like to present Dr. Fatma Subhi and PRP and fat grafting for improvement of scar.
First of all, thank you very much, Dr. Ziad, Organizing Committee, Scientific Committee, for giving us the opportunity to present today, and for this magnificent, really 2 days event. And also I would like to thank all our distinguished speakers from these international speakers and the local speakers. Actually, there is a lot of knowledge, new technique and experience. We've been enriched really in the last 2 days. And I really feel humbled presenting my experience in treating this burn patient in our department. So in the Bin Sultan Military Medical City, we have a burn unit which is headed by our colleague. She is a burn surgeon and she's doing a lot of burn patient. And actually, I'm a hand surgeon. I don't do a lot of burn. But it happened that I have some patients that I have to treat since I started my practice a few years ago. So we know that scarring, as have you seen with all these presentations, they really affect the patient physically and psychologically well-being. And always we have to have an effective treatment strategy to treat them and address the functional impairment and the aesthetic appearance of their burn scars, which can affect their self-consciousness and the psychological distress. So when we talk about the physical consequences, we know that it's abnormal scars they have or abnormal skin. It's not just only the impairment of the functional movement, also it is the itching, the pain that they have, the discomfort they live with. And these keloid scars and sometimes the hypertrophic scars, from the itching, they can currently open and open again, and they have these chronic ulcers that are really difficult to treat. Even if there is no that physical impairment, small scars in the face on some girls that can affect their relationship in the society and cause this social withdrawal. So I have these two. So I said I'm not a burn surgeon. I don't do a lot of reconstruction of burn, but it all goes to my colleague. So it happened I have these two patients over the last few years where they started with an extensive burn all over the abdomen, chest, breast, and the axilla, and extended up to the neck with the intestinal contractures I have seen with our previous lectures. It's very tight, adherent skin with a lot of contracture bands and a lot of tight lines over the joint and other than the joints. In our burn unit, we have multidisciplinary team which treat the acute burn cases, but for those old burn scars, it's just only us, the plastic surgeon and the psychologist. And the psychologist with us is a full-time always, because really we find out that we need them in the unit because these patients, they have multiple procedures, and if we need to follow the ladder of reconstruction, we are doing a lot of operation of tissue expanders or sometimes a free flap for them. So the maximum probably for this patient, we run 2 procedures per year, and it can be interrupted, and we have to recall them again. So we do tissue expanders. It's sometimes difficult when there is a limitation of intact skin to do the reconstruction. You have to go with this with skin graft, with skin substitute. We tried with them everything all over the last few years. So the first patient I had, the jury, I had her at the age of 7, and she was like contracted everywhere, and she wasn't moving, even the shoulders, and the neck is very tight and tucked, and all the scars is going down to the abdomen. Over the years, we put the tissue expanders, we did a lot of release and skin graft, and every time she comes back, we have to do some release, but at least the neck was started to mobilize. Then I noticed that my colleague, she's like did over 200 cases of PRP injection alone, or sometimes she combined the PRP with the fat injection, and we saw a lot of significant result with the keloid cases, the hypertrophic. So I said, why not? Well, let's start and do, let me just adopt this procedure and do it on this patient. So we combined the PRP to have the tissue regeneration we know, and the fat injection just to help restore the volume. And the main thing is to create a new layer of subcutaneous tissue, which is usually lost in all these burn patients because of the fibrosis and the scarring. There is no tissue, it's just adherent, so you need to create more pliability. So we combine the fat with the PRP, and we put them together and we inject them in the area. Harvesting the fat is just, we can do this manual or conventional liposuction machine or vaser or micro air. And in the preparation, it's very simple. We didn't do any wash. We just break down the fat. We centrifuge if we need a small amount for the superficial skin in the neck or around the face. No nano fat. And I use also in both patients, I'm gonna present the lipogem technique that advertised by one of the companies, where they just shake the fat, they don't put it in the machine or centrifuge it. And I try to compare the two results between the two areas where I use just a fat without any centrifuging or the lipogem fat. So what I do in the abdomen and the chest and the breast, I just release with a spatula, very extensive release. And the face and the neck, I use the 18 gauge needle, and around the nipple area, I just release it with the 18 with the needle. I mix 1 cc of the PRP. I usually take 20 cc from each patient. So I come up with 8 cc from the 10, and I take 1 cc and I mix it with another 80 cc of the fat if I'm gonna need to inject it very superficial. Otherwise, I use all the fat just to create a subcutaneous layer, and the fat just to make the skin more pliable. So this is jury from the beginning till today with a lot of tissue expanders and release. And if you can look at how the scar, I don't know if I have another pictures for her, no. So we can see she wasn't like when she gaining weight, the abdomen is around the restricted band, is just tucked in. She doesn't have this flexibility of expansion in her abdomen and her chest. And the repeated procedure I used to do for releasing the neck, the scar with the skin graft became easier and less for us, that I don't have to keep going and doing it. The other patient, I use again tissue expander to create the inframammary fold, as it was really tight and it wasn't growing in compared to the right side breast. When it has really a laxity, I start to inject these fat grafting and the PRP for her. And you can see how this band around her abdomen became very lax, and the difference in the color and the shape. So in the patient, always when jury comes to me over the last few years, the parents they feel that she improved, she gets better, but jury herself and myself always like, we see there is a lot of things to do, we have to do more so she can look normal. But when I started to do the fat injections with the PRP, she was like, I want to more sessions. I want to do it because I feel relaxed. The skin is smooth. It's not tight as before. I can move. I can breathe better than before. So in our inspection, when we look at the skin, we can see there is less redness, there's better color, and it's a smoother texture. So we found that it is a quicker procedure. I can do more for them during the year because they are growing and they are coming to the college and they are coming to a certain age that they want to really get faster recovery. This procedure with less anesthesia time, less complication, and less morbidity than the tissue expander. It doesn't replace it, but it can create a room for more improvement. The side effect is very less. I never had any seroma or hematoma or infection. Always the complaint is minor discomfort, and they didn't really care about that. So I think this doesn't remove the scar like our usual technique of a free flaps or the tissue expander, but for them it just really make the patient more happier and more communicator with me myself. When I looked at the literatures, I saw a lot of really very good result with these 2 days presentation, but I couldn't find really any publication about combining the PRP and the fat injection to improve the old burn scars. Probably the only one which was really that Dr. Ziad spoke at the first day that he used it in the patient and he presented the case. And I recommend that reading this article because it is showing a lot of details on how to use this technique. Otherwise, you would hear about the PRP or the fat injection in the donor site healing or acute burn or chronic ulcers. Otherwise, it's been used in acne and atrophic scars, are also the other articles about the Botox using it for the scar management.
You have less than 1 minute.
I'm done. Thank you.
Okay, thank you very much. So the next speaker is Dr. Sabrine Al-Zamel, and she's going to tell us something for fat grafting for scars.
Assalamu alaikum. I would like to take this opportunity to thank Dr. Ziad for re-inviting me for his special events. It's really informative, and I'm so proud to be among this distinguished crowd. Thank you. It's really difficult to speak about scar management with fat grafting in front of the masters of fat grafting and in 10 minutes only, so I'll try to be concise. The cases will be presented in this talk. Oh, the numbers are in... before 2009, 2010, I referred to as lipofilling because I didn't know about the contents of the adipocyte stem cells in that time. After 2010, after I'm attending lots of workshops and conferences about the enriching fat with stem cells and the inclusion of the pellet, then I named it as fat grafting because it has a regenerative effect rather than a filling effect. Why fat graft improves scars? Because of the regenerative ability. And this regenerative ability is because of the content of the adipocyte stem cells. Moreover, even damaged adipocytes, dead adult adipocytes, when they are damaged, they release further factors that also improve and affect positively the regenerative process of the adipogenesis. The first case series I'm going to introduce is about skin abnormalities. The most famous one is post-acne scarring. And since this is in the early 2000s, I only used lipofilling. Again, another acne scarring, we can notice that the pits and depressions are becoming more shallower, and we can see on your right hand the post pictures together with the effect of dermabrasion that I don't combine with. I do the dermabrasion in the winter, and then I do the lipofilling that time in the summer. All the numbers are in Arabic. 19-year-old gentleman, he presented with a depression of his, or extenuation of the forehead crease at rest. It's very eminent, although he's 19. This is him with eyebrow lifting, and this is him with eye closure. Though I did it 2014, I prefer to do lipofilling because here we need the filling effect of the fat more than the regenerative aspect. This is him with the eyebrows lifting, and this is him with eye closure. The second lady is a young lady with skin warts. We did serial excisions on 2 times, and this is her scarring after full excision. It's a very thin scar, and there is a depression and little bit of emptiness, and lost a bit of the eminence of the upper buttock projection. This is how I did the rhizotomies in her. I usually do it with 18-gauge needle, but this scar was very shallow and it was very fragile, so I used this malleable needle. And this is how I do. It's not working. The video is not working. This is how I do the fat grafting nowadays. I use the spaghetti technique, small syringes, and I do the aspiration injection technique. Anybody, please?
Could we get some technical assistance?
Kindly, some help? الله يخليك.
ايش صار دكتور؟
This is her post-op, the one with the dressing. We can see an elevation of the scar and little bit of augmentation of the buttock just to be closer to the... Now, this is when we inject, I try to get the assistant to restrain the injection, the fat at the area of injection, to refrain it from actually spreading in another place. And this dressing is to actually reinforce the purpose we wanted. And this is her post-op and pre-op. Post-traumatic scars. This girl had a car accident at the borders of Kuwait and Saudi Arabia. She was stitched at the border hospital, which I think it was nicely done. This is her, 2008, with lipofilling. That time, I didn't know how to use the adipocytes-rich fat graft. This is her after a few days. This is her after a year, only one session. And this is her 2013 and 2020. This is, again, a lady who had a road traffic accident, and she ended up having scarring of the eyelid and the cheek. A colleague of mine nicely did a scar release and full-thickness skin graft and dermabrasion of the cheek. This is her, when I received her, she still had some contracture on the eyelid and some scarring. I did a Z-plasty of the eyelid together with fat grafting. We can see that this depression on the temporal eyebrow has responded well. And if you pay attention, you might think there is no response here, but I would like to draw your attention that the zigzag appearance of the Z-plasty done has actually disappeared with the normal horizontal crease of the eyelid due to the fat grafting. This is her with eye closure. Her sisters told her that she actually is able to close her eyes during sleep. I didn't like the pit on the opening of the lateral canthus, so I tried to give her more fat grafting. Again, she was not happy with the sausage appearance of the fat grafting, the second one. However, I told her in order to excise it, everything will go back to the same way. She was convinced. This is her cheek post nanofat grafting, and this is her cheek before nanofat grafting. You can notice only the anterior part of the cheek has improved a bit. She needs a second session. Now, she is concerned about this bulge on the temporal area, and she's asking me to lipoaspirate it. I told her to wait for a year, and we will see. And I'll do some radiological examination in form of ultrasound or MRI to know whether it is already fibrous or not. This unfortunate lady was subjected to multiple dog bites when she was, by 6 dogs, when she was a child, and she was actually affected everywhere in her body. But again, she's studying master's and PhD here in Saudi Arabia. She's a Kuwaiti, and I only did 1 session for her so far. The green part is the liposuction, and the red part is the fat grafting. I used the hill to fill the valley, just to give her a semi-normal contour of her thigh. Post-burn scarring is very challenging. This is 2010. I did only lipofilling that time. She had a scanty donor area. I used the banana folds and tried to use them to create the upper pole fullness of the breast and to give her sort of a cleavage. This is her on the oblique view. This is a brave 16-year-old boy who was involved in a major flame burn. He was in the ICU with us for around 3 months. Everything under the sun that for treatment of burn was done, including tissue expanders. The second time, tissue expander was planned to be put in the redly marked area, but he refused. He was so much into agony and impatient to do surgeries that take so long time. So I offered him to give him a fat grafting on the area of the skin graft. So this is
1 more minute,
including the disturbance. No, I have. And this is the skin graft after the fat grafting. I use this area of liposuction for the contour. He keeps sending me his photos on Instagram, and he keeps showering me with blessings and prayers. Contracture bands, I again use this part, which is actually feasible by excision. Before excising it, I use the fat content of it, and I injected it into the areas circled. And this is before and after 1 session. And this girl is a 10-year-old girl who excellent student. She doesn't want to quit school. She only wanted to perform better in ballet sessions, and she couldn't, so because of the contracture rendering her arm extension. So this is before and after 1 session of fat grafting. Babies do better. This is 1 session of fat grafting in a baby. Why do hypertrophic scars respond well? I personally believe in the beta transforming factor, which is responsible for irregular arrangements of the collagen bundle, which is at the same time inhibits adipogenesis. So if you reverse the equation and give fat, then the beta transforming factor effect is less, and thus this will help reduce and improve the hypertrophic scars. Iatrogenic post-steroid injection, post-orthopedic operations, post-orthopedic operations after 3 sessions, and post-complicated laparoscopic appendicectomy, open and with drainage. This is her before, and this is her after 3 sessions. Self-inflicted injuries, a tattoo in the forehead. They have the habit of locally doing it with, scrubbing it with lemon and salt. This is her after 2 sessions, and this is the lateral view. This is post-suicidal attempts in attention-seeking behavior, both forearms. This is her before, this is her after. before and after. Note the area in the red circle. Complications, I had only one complication in this girl. Maybe I had an performed offer enthusiastic dichotomies. It ended up in this way, and unfortunately after debridement I didn't see her. Apparently she went to another colleague. I don't blame her. So then I learned when I should be stopping the injection. I learned that in the lady with the multiple suicidal scarring, and I was able to save her without any complications. Prevention, we should know that injection should be discontinued when the skin becomes blanching, or what I call fat spitting, that the fat resists to enter the opening anymore, and to plan several stages. In conclusion, the fat grafting is an impressive tool, and it's easy tool for scar management because of the regenerative aspect. It's even more prominent in the tissues that had chronic inflammations and abnormal inflammations such as scleroderma or irradiated breast tissue. Results depend on the technique of harvesting, proper patient selection, handling, and reimplantation. Besides, the bonus of liposculpture is, and complications are rare in expert hands. The drawbacks, scanty donor area, requires several sessions, time, and tool consumers. Thank you.
We'd like to present for you Dr. Abdul Karim. No, yeah.
طلع لي I loved this session. It was really very rich. It's okay. It's okay. Just حط لي yes, perfect. So good morning and good afternoon, everyone. This session was very interesting. I will be talking about advances in wound care, but I will be focusing on re-epithelialization. For our young surgeons, our residents, they have to know that the re-epithelialization is the fact that the epidermal skin will cover as last step the wound, and it supposes that the wound bed preparation was done properly. We cannot talk about re-epithelialization while you have, for example, an infected wound or a wound with a lot of necrotic area. So it passes by a very good preparation of the wound bed, a good debridement. We have seen how Nelson Piccolo, he did a good debridement of the wound, and then we need to focus also on preparing the patient, treating the comorbidities. Okay, and then we use some other tools to promote the regeneration of the tissues, and lastly, the epithelialization and the growth of the epidermal cells. Now we are using tools. I am using the PRP. I'm using the fat, the microfat, the nanofat, the fat as dressing. I will do it more after attending the prestigious presentations of my colleagues. But now I will be just focusing on the re-epithelialization. So this being said, I would like to disclose that my presentation was sponsored by BioRemedy and partially their product called Licoxan. I will be talking about it later. So I always say to my resident that the scars, they are the memory of the skin. Whatever will happen to our skin, it will keep a scar. We have to do and to work to have a good scar. If you deal good with your wounds, you will have a good scar. So any injury of the skin is a stress, whatever it's a burn, a surgical wound, a laceration, pressure injury, vascular, chronic ulcers, or a diabetic foot. This is a textbook, okay, just to say that the re-epithelialization, the keratinocytes will proliferate, migrate at the edge of the wound to extend a newly formed epithelial carpet made of several layers of cells in the epidermis. And then the epidermis will not grow in the space. It will grow over a matrix, over a granulation tissue of a good quality. So by definition, we cannot talk about healing of a wound without having this layer of epithelial cells. So in the absence of re-epithelialization, a wound cannot be considered healed. In this process, if this process is impaired, we will have all those types of chronic wounds. The failure of keratinocytes to maintain this barrier may contribute to wound recurrence. So the epithelial cells, the keratinocytes, they will pass through steps: the proliferation, differentiation, migration, and there are many markers that we can use to follow this process in the different layers of the epidermis. What we discovered, not very lately, but that the keratinocytes start to work since the first hour of the injury, especially in acute wounds, okay? And then there is other discoveries that in the epidermis can constitute an independent neuroendocrine organ. The keratinocytes has very big immune function. They can respond to mediators. They can that can affect their function by inhibiting them, activating differentiation, activating migration, and so on. So many studies were done in this, and there was they discovered like epidermal stem cells in some niches of the skin, especially in the bulge of the hair follicle, the base of the sebaceous gland, and the basal layer of the interfollicular epidermis. Mesenchymal stem cells are residing in the bone marrow, and they participate in the re-epithelialization by inhibiting excessive inflammatory responses. So here just a list of the mediators that affect the keratinocytes, migration or proliferation or inhibition of the proliferation also. So the research, we are talking about tissue engineered human skin equivalent, just to try to make something that looks or that works like the keratinocytes. So in research, there are also the human allogenic keratinocytes and fibroblasts in a spray formulation, viable cells within bioengineered construct as compared with the matrix, and also the effect of the PRP and the adipose-derived stem cells on wound healing that continues to progress more and more because it is cost effective, it doesn't need a lot of technology, and wound care is really costly. So for the epithelialization, it is not something universal or something organized or something like that can be done systematically. No. In vivo and in vitro experiments, they present a disordered border evolution which indicate a possible universal irregularity owing to chemotaxis. So the epidermis will not grow the same way on the same places on the edges of the wound. So if we talk about wound healing, impaired wound healing can be grouped into categories. If there is excessive wound healing, it will lead to hypertrophic scar. If there is an incomplete wound healing, it will lead to chronic wound. Very schematic. Okay, for this photo, it is showing how is the healthy skin on top left, okay? In the other photos, as well for the venous ulcer or for the diabetic foot or in the pressure ulcer, we can see that the epidermis is thick. So there is a proliferation, there could be a differentiation, but there is no migration. It doesn't push on both edges of the skin. So what's the cause? Multiple causes in research. The excess of matrix metalloproteases, we will talk about that. Impaired fibroblast signaling, extracellular matrix instability, and stalled keratinocytes migration. So for the MMPs, the metalloproteases are a family of endoproteinases, primarily implicated in the degradation of damaged extracellular matrix. So they clean everything up to allow the body to build new tissue, new matrix, so the keratinocytes can run and migrate on it. The keratinocytes and the fibroblasts and the endothelial cells and inflammatory cells can control the MMP's activities. So in acute wounds, the MMPs are very low in normal skin, Okay, but in chronic wound, the chronic wounds are characterized by elevated levels and activity of the MMP and concomitant abnormal low levels of their inhibitors. That's why there is a delayed or absent wound closure. All this chain will disrupt the equilibrium between synthesis and remodeling of extracellular matrix, which is a key determinant of the successful skin repair. Numerous treatments have been developed that aim to and target MMPs in chronic wounds to reduce their negative effects, but effective therapeutic options to reduce that activity are still limited. Also, some small note regarding the biofilms that will impair the migration of the keratinocytes. The biofilms can contain some microorganisms that are more resistant to the antibiotics. So it is really very important to deal with this biofilm. So what next? Globally, the advances in wound care products market, according to Report Linker, will reach 18.7 billion by 2027. So we can see how costly is this field. Also, the Advanced Wound Care Technologies 2030, they report that by the year of 2030, there will be like $22 billion in market for advances in wound care. On the other hand, let's see the risk population according to the WHO. So by 2030, there will be 1.4 billion of population older than 60 years old.
You have less than 1 minute.
Okay, perfect. I will do it very fast. So that's why we are in the obligation to develop cost-effective technologies for wound care. Naturally derived ingredients, natural ingredients that are cost-effective in accelerating the wound healing. At the same time, consumers concerned about the chemical and side effects of classic drugs. So, as I said in the beginning, re-epithelialization means a good preparation of the wound bed. So I discovered I was informed by the colleagues about a molecule, the proanthocyanidine with silicone. Actually, the product Lecoxen has a unique combination of proanthocyanidine with silicone. Usually we use silicone to treat scars, but here the silicone is used to heal the wound. So the proanthocyanidine helps the mobilization of fibroblasts in the wound site and inhibits the inflammatory response through decreased expression of the monocytes. Other studies, they are talking about topical treatment was associated with a more well-defined hyperproliferative epithelial region, higher cell density, enhanced disposition of connective tissues, and improved histological architecture. Also induced VEGF expression in human keratinocytes. So the proanthocyanidine is extracted from grape seed. Okay, it suppressed the mRNA level of inflammatory mediators. For the silicone, I actually found only one study talking about using the silicone in the wound healing. It promotes the wound healing by facilitating epidermal migration through modulation of electrical charges in addition of bacteriostatic properties. So just 2-3 cases. Okay, this is just an abscess. This patient came to me like this. I made sure to prepare my wound correctly, and then I started to use the Lecoxen to accelerate, to promote the keratinocytes proliferation and migration. And by day 17, it is perfect. If it came to me like 10 years ago, perhaps I would just throw a skin graft there.
Please come to an end.
I will conclude. Day 1, day 42, patient refusing surgery, excellent quality of reconstruction after chemical burn, a failure of skin graft partially treated by the same Lecoxen. And this is my last patient. I have used for her microdermal graft with microfat graft, okay? And I was surprised how by day 16, using the Lecoxen externally for the epidermal growth, it gave a really excellent result. We can see there how the epidermis is growing. Thank you very much.
Thank you very much. It was an excellent session. I would ask the speakers to stay here for a short photo, and then we will go to lunch, and the lunch will go until 1:30, and then we're going to commence with a rest. Thank you.
7 presentations كلها كانت free abstract. البروف هتبدا ببشير غازي، هذا من البرازيل، ودينيس ديجلس، انت يا فارس، هذا من البرازيل. هذول الاثنين كلهم فيرشوال، الاول والثاني. بعدين وسان وساره واحمد ومنير وعبيد لا هذول.
طيب كيف بتبدا؟
بشير غازي يبدا فيه.
بشير غازي؟
بشير غازي from Brazil.
From Brazil. We can start. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. It's our pleasure to start this session. Thank you for the organizing committee, for Dr. Ziad for the excellent conference. جزاكم الله خير. The first presenter, Dr. Ghazi, Bashir Ghazi from Brazil. He will present liposuction experience and update and technology. Virtual. He will be replaced by Dr. Therod from Brazil. غير. Theodore.
Hello there.
Welcome.
Thank you. Can you all see my slides? Everything's good?
Yeah, everything is fine. You can start, please.
Excellent. Thanks for having me here. It's a real honor to be able to present to you all. I'm going to talk about my experience today with breast augmentation using Sientra silicone implants and concurrent fat grafting. It's something that we've been doing for several years now, and I'm excited to share with you our experience with this combined technique. So what we're talking about today is composite implant and fat grafting, and it's the combination of breast augmentation with fat grafting to provide a single surgery for our patients. And this is a very powerful technique, as you'll see, because it helps us achieve the desired volume in patients, particularly those patients who have a lower body mass index, so they're thinner patients, and those patients also have relatively thin native breast tissue. And so, as you'll see, it's a very effective technique for giving these patients the results that they desire, because you're able to not only give them what we call core volume projection, which is from the implant itself, increasing that projection in the middle portion of the breast, but it also provides a more natural looking and a more natural feeling breast reconstruction or breast augmentation because of the fat grafting. And so we are also able to do this with a variety of breast augmentation techniques, including the subfascial technique or using either a prepectoral plane or a subpectoral plane if you really wanted to. And so I'll start by giving an example of this patient. This is a relatively young patient in her 30s. And as you can see, she has bilateral breastosis and a little bit of nipple asymmetry. So what we wanted to do with this patient is we wanted to give her an augmentation. She wanted to be slightly larger, but as you can see, she has breastosis. So we planned for a mastopexy as well. And in this patient, you can see what I've drawn here is where fat grafting was anticipated, which is in the superior pole of the breast as well as the medial pole of the breast. Now, this patient also needed some fat in the inferior pole, which is variable depending on how much soft tissue that she has. So what we planned for was an inframammary incision for the augmentation, followed by at least the periareolar mastopexy, and then fat grafting, all together in one operation. And here are the results. You can see that she has an excellent contour here at the inframammary fold. And what the fat grafting really does is to improve your results after augmentation, because you're able to better soften that transition from the patient's chest wall down to the superior pole of the breast. Now, this patient ended up just needing a periareolar mastopexy, and you can see that we placed a modest 200 cc moderate profile implant, and then I injected 100 cc's of fat per side. And so that 100 cc's of fat was really critical in giving an excellent result and making this patient really pleased with her outcomes. Some of the key points of doing this combined operation is that, I use power-assisted liposuction. I think that it provides me a lot of fat very efficiently. As we said, a lot of these patients are relatively thin, but you can get a good amount of fat from the bilateral flanks, the abdomen, and the thighs. And that's the most common place that my patients ask me to get fat from. Generally speaking, for these types of patients, I do the breast augmentation first and then mastopexy. I've had a lot of discussions with colleagues of mine whether you do the mastopexy first to get the shape right and then you do the augmentation, or you do the augmentation first to get the volume that you want and then you do the mastopexy to get the shape right. In my practice and in my hands, I've had a lot of good success with doing the breast augmentation first, and then figuring out how the skin drapes around the implant to determine the type of mastopexy that I need. So if after the augmentation, like the patient that you just saw, there's some nipple malposition, then I would just do a periareolar mastopexy, and that's what she needed. So that way I don't commit the patient to any additional scars, such as with a wise pattern mastectomy, a wise pattern mastopexy. And then there's the fat processing and fat transfer portion of it. So you can harvest fat with any kind of liposuction. We'll talk a little bit about the kind of fat processing unit that I use, which is from Sientra actually. And then you transfer the fat right after all of your breast operations. And so this provides a very safe procedure that then obviates multiple operations, particularly in a cosmetic patient. So I want to show you more about how powerful this technique can be when you combine these procedures together. You can see on the left-hand side, this a patient in her 50s at the screening appointment. You can see she has, the classic deflation of both breasts. She's had several kids in her life. She has relatively large nipple areolar complexes, which will influence the type of mastopexy that is required. And you can see that she has some significant breast asymmetry, particularly along the folds, and she has some deflation in the inferior pole as well. So this patient, needed an augmentation, and that's what she desired. But we combined it with fat grafting as well to give her more of a transition, again along the superior and medial poles of her breasts. So you can see that the implants that we placed were 330 cc's, 345 cc's, and then just a little bit of fat that was injected, 50 cc's and 62 cc's, really serves to soften up the transition zones that are really important. So in this patient, what I'm really focused on is this transition zone between her relatively thin upper chest wall and the superior pole of the breast. as well as this very, very critical medial portion of both breasts right there. As I said, the implants that I'm using now are Sientra implants. I've used Mentor implants for many years, and so I have lots of experience with both. But right now, I'm using Sientra implants, and I know that Sientra implants are available over there. And I've had a lot of good success and a lot of excellent patient satisfaction with the Sientra implants. I think that there are several unique things about these implants. Obviously, they have several lines of their implants, but in general, I really like the consistency of the gel. I think that comes from the cohesiveness of the kind of gel that Sientra offers. And also particularly for these patients that we're talking about today, cosmetic patients, thinner patients, patients who don't have a lot of subcutaneous fat to hide the edges of the implant. You really want an implant that has this flat back design, because it really does improve the palpability and the amount of wrinkling that you get. And this combined with the fat grafting that we're talking about at the same operation, I think really gives the most optimal results. The other thing is that um, the FDA in the U.S. Has required all of the major implant companies to report their safety data, and so all the implant companies had to provide their 10-year clinical safety data to the public, and so this is all published information. And Sientra has the lowest complication rates. What in my practice, what I really care about, particularly with cosmetic patients who are paying for their implants, is the rupture rate, um, because for us in the United States, the rupture rate is probably the most talked about complication, particularly with silicone gel. And Sientra has a rupture rate of 8.7% in their 10-year study. And what I look at in my practice, when I compared all the published rates of complications, if you look at the primary augmentation data, but also if you do reconstruction like I do, you can look at the primary reconstruction data just below it. You can compare the complication rates for all of the companies, and you can see that the rupture rate for Sientra at their 10-year study was 8.7%, and that's significantly lower than the other companies. So that to me is very important in my practice. When I talk to patients about the type of implants that they're getting, I will show them this information, and they can see for themselves that the implants that they're getting are the safest that are available in our country. So yeah, this is just to identify that. So a little word on the fat grafting process, as well as the unit that I use. So I use Viality, which is also offered by Sientra. So I know that this is not available yet in your area. I hope it is soon. I would just say a little bit about this. Basically, it's a pretty simple three-step process that is required. First of all, you harvest fat in the same way that you normally would. So I use my power-assisted liposuction. I connect that to this unit, so it's an inline design. So it's very easy to use. There's a filter that's built into it, but one of the most unique features about this is that there is a very large range of fat that you can collect and then later graft. So this unit allows you to have from 50 cc's of fat to over 1,000 cc's of fat. Okay. Previously, I had used a lot of the Revolve from Allergan, and so you needed a minimum of 100, but the maximum was basically 300, 350 cc's of fat. So if you're doing large fat grafting procedures with breast or non-breast fat grafting, elsewhere in the body where you need a lot of fat, you really need a unit like this that gives you a broad range. Okay, so that's a unique thing about this system. Another unique thing about the Viality system is that it comes with this surfactant called P188, which they're calling Oriclens. Okay, And this is something that it comes with the kit. It's in the powder. You reconstitute it, and it really it's a surfactant, which means that it's used to kind of cleanse the fat that you have. So that's done manually, intraoperatively, and I think they're coming out with more and more data about how this P188 additive, or the wash really, will improve the fat grafting retention rates. And so more about that, I think, is coming in the near future. And then there's other features of this unit. So for example, there's like a little tray down there that you can remove to allow for more absorption of the fluids, so that will concentrate your fat even more. So hopefully you guys will be able to get this where you are soon. So going back to augmentation and fat grafting and the power of this technique, you can see this will be the last example that I have, which is very, a significant one, which is this is a lot of breast asymmetry. So this is a middle-aged patient who has lived like this for decades and decades, right? And with no good solution, and this kind of borders between cosmetic and reconstructive, right? She has such severe breast asymmetry, and both breasts actually have a number of issues. So if you look at the right breast, there's deficiency of fat in the superior pole, and then there's obviously a lot of ptosis in the right breast. That nipple needs to go up multiple centimeters, and actually the breast base is a little constricted, so she has a little bit of a tuberous breast deformity on that right side. On the left side, she has a hypoplastic breast. Okay, that inframammary fold needs to be completely reconstructed, in my opinion, and brought down. And clearly she has a large amount of asymmetry in the volume of that left breast. Okay, nipple is relatively high, especially compared to the other side. So the plan for this patient is going to involve a combination of mastopexy procedures, augmentation procedures, reconstruction of that left fold, and a lot of fat grafting. And so this patient really benefits from the combination of the augmentation with an implant as well as with fat grafting. And so this was a very difficult case, and I'm pleased to say that the patient is very happy with her results. So on the right side, what was necessary was a relatively smaller implant, 200 cc's of an implant. And then remember, she had a lot of deficiency on the superior pole. So she actually received 240 cc's of fat that was grafted throughout the breast. And then she also had a wise pattern mastopexy, as you would expect, to bring that nipple up. And then on the left side, you can see what she has is that we had to bring this inframammary fold completely down to match the contralateral side. And then she actually received a larger implant, as you would expect, and much more fat, 450 cc's of total fat. Okay, if you add this amount of fat together, 450 plus 240, that's not possible with the other fat grafting systems that are out there currently. So one of the reasons why I like using this Viality is because it allows you to have 1,000 cc's of fat, which, as you can see from this patient's body habitus, was easily attainable. So this shows you really the power of combining the breast augmentation operation as well as fat grafting at the same time. It really shows you your results in real time, and it allows you to provide this kind of outcome without having the patient do multiple staged operations every few months. So in summary, I do a lot of augmentation and fat grafting now in my practice. I think it really is a powerful combined technique, and we have shown that it provides lasting results with a lot of reliability. And you can do it in a multitude of patients. I showed you 3 examples, and this is the 4th example. Patients of all different sizes, breast asymmetries, and patient desires. It is possible with a wide range of patients. And so like this patient, for example, she wanted a relatively small augmentation, And we still use a little bit of fat grafting because if you can just tell in this picture, that implant is not going to reach the very upper transition areas of her thin upper chest, which is just under her clavicle, and the just that little fullness of the medial aspect of the breast. That's really what patients want when they're wearing a bathing suit, when they're wearing clothes. They want to feel fullness there, and so it really helps to augment the results of your augmentation. So the addition of fat grafting at the same operation really enhances your aesthetic results, and it complements the effect of the implant that you're using. Okay, and so what we have really enjoyed doing this operation is that we can readily and safely perform both fat grafting and basically any other breast operation that you do, whether it's augmentation, mastopexy, or breast operation. So with that, I want to thank you for your attention, and I'm happy to take any questions if you have it. But thank you.
Thank you so much. We will leave the questions to the end of the session. Now we have to move forward for Dr. Zaid, evolution of SMAS facelift techniques, comprehensive systematic review of complications and outcomes.
Assalamu alaikum. Good morning, everyone. Thank you a lot for having me, and I feel very honored to be here. And I'm very honored to share with you one of the recent results that we encountered in the last publication me and my colleagues have encountered. Our research titled Evolution of Superficial Muscular Amniotic System Facelift Techniques. This is a comprehensive systematic review of complications and outcomes. My name is Wasan Al-Zaid. I'm a resident doctor currently working in CASH. Well, facelift was first modernized by the French and German surgeons back in the 1900s. However, due to public perception, it was kept secret. Then, during the Second World War in 1940s, many soldiers left with disfigurements, therefore prompting significant advances in the field. These improvements led to the development of newer techniques such as SMAS, along with subfacial flab by some pioneers in the field such as Torts, Cook, Mitz, and Pironi. Today, various techniques exist such as SMASplication and lateral SMASectomy. SMASplication, according to a recent study, is considered to be the most popular technique due to its longevity and decreased rate of complications. Whereas lateral SMASectomy also offers a comparable result. This is an illustration showing various SMAS facelift techniques. First of all, this systematic review was registered in Prospero. We conducted this systematic review according to PRESMA guidelines. A comprehensive literature search was done in the following databases: PubMed, Medline, MPACE, Cochrane Central, and Google Scholar. The search was limited from January 2000 to September 2022, just to make sure that the data we receive is just related to the newer techniques. And these were the search terms. We chose the selection criteria based on many factors. For example, mostly English literature only, studies involving human participants undergoing SMAS facelift for only cosmetic reasons, and complication rates must be reported, and each single one of the study has more than or equals 20 adult patients. Only original articles were included, and publication between January 2000 to September 2022. We started by excluding articles that did not meet our inclusion criteria. We first screened by title and abstract, and then by full text. We screened using Ryan. The initial requirements were a distinct explanation of the facelift technique. It's one of the following 6: SMASplication, SMASectomy, SMAS flab, high lateral SMAS flab, deep plane, and composite. Now, regarding the data extraction, we formulated a data extraction sheet. We extracted the following data: author, country, study design, sample size, PMI, patient age, comorbidities, type of facelift used, and every complication reported. And we quality assessed using minors, and also we utilized the American Society of Plastic Surgeons levels of evidence. We analyzed the data using a narrow synthesis approach. However, due to the heterogeneity that we encounter in the data, unfortunately only qualitative synthesis was possible. Meta-analysis was not possible. And despite the lack of meta-analysis, we truly believe that this narrative synthesis provides a comprehensive overview of the effectiveness and safety of these SMAS facelift techniques. Now, this is the PRISMA chart of every article we encountered during these screenings. So, for example, we found 1,865 in Medline, 1,112 articles in MPACE, 1,115 in Cochrane, and 200 articles in Google Scholar, with a total of 4,292. So after removing duplicates, we end up with 2,382. And after assessing inclusion and exclusion criteria, and after reading the full text, we end up with only 27 articles in this study, with a maximum of 6,086 patients. This is an overview of the included studies. And this is the minors assessment for every one of them. Now, regarding the clinical characteristics of the patients, we found that most of our patients is from 23 to 89 years of age, with a mean of 55. 95% of them were females. Most of our patients did not have any obvious comorbidities, but we found that 13 were hypothyroid patients, 150 were hypertensive, 28 having some coagulopathies, and 12 were diabetic. 82 of our patients were smokers, and we also accumulated the data regarding the adjunct procedures that was done at the time, and we found that 400, for example, did have upper blepharoplasty along with the facelift. 362 had fat grafting, and so on. And we also measured the patient satisfaction using FACE-Q test. And we found that more than 85% of our patients were satisfied with the outcome. So in conclusion, the results suggest that SMAS flap technique has the highest complication rate, whereas SMAS application has the lowest. The most complication that we reported, was reported in the literature is temporary facial nerve injury, hematoma, skin necrosis, in only one case ever reported in the literature with permanent facial nerve injury. Of course, this study, like any other studies, has some limitations. For example, the heterogeneity of data that we encountered, and the potential of publication bias because most of the publication or most of positive results are published compared to negative results. So we recommend that future research should focus on addressing these limitations, and also, for example, in the future, a large scale prospective study would be very great with a longer follow-up time. This would generate more reliable data that we need, and also studies that compare different techniques so we can identify the optimal technique, for example, for every population, a different patient population type. Once we have sufficient similar studies, of course, meta-analysis will be possible. Thank you so much for listening.
Thank you, Dr. Hassan. Now we'll move to the next speaker, Dr. Sarah. I don't know if she is available, Dr. Sarah. No? We'll move to the next speaker, Dr. Ahmed Abel Wafa. He will talk about extended L-shaped spreaded graft for correction of combined dorsal or caudal nasal septal deviations.
بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على أشرف المرسلين نبينا محمد وعلى آله وصحبه وسلم أجمعين. I would like to thank all the organizing committee. Special thanks to Dr. Ziad Al-Harbi for inviting me to present my experience in this topic, which is the very important topics in the nasal surgery, which is the correction of the dorsal nasal cartilaginous dorsal deviation by extended L-shaped spreader graft. As we know, global definition of the nasal deviation is the deviation of the nasal pyramid from the midline. This deviation can be in the form of C-shaped, S-shaped, or total displaced to one side. And the axis of deviation can be cephalocaudal or anteroposterior. The nasal deviation, it is a big challenge for the rhinoplasty surgeons because it has functional and aesthetic and psychological impact. The nasal deviation can be, the most common cause is trauma, but it can be developmental or congenital. These are photos for different types of nasal deviation. This is C-shaped deviation. This is S-shaped deviation and total deviation to one side. As we know, the main contributor for the nasal deviation is the septal deformities. So, septal surgery plays a vital role in management of deviated nose. Now we have to determine exactly where is the deviation, where is the deformity, in the nasal bone or in the cartilaginous portion of the nose. If it is in the nasal bone, it can be corrected simply by different type of osteotomies. But the problem if it is in the cartilaginous portion. If it is in the central part of the cartilaginous portion, this can be resected with the usual technique of septoplasty. But the problem, if the deformity is the cephalocaudal L strut, that is responsible for the nasal support. If the deformity involving this strut, this is a challenge for management. We have to consider that proper skeletal support is necessary to provide long-term aesthetic and functional results. So we have to keep and preserve the structural integrity of this L-shaped strut after doing septoplasty. Now, if the deformity involving the L-shaped cephalocaudal L-shaped strut, there are many techniques have been described to correct with preservation of the nasal support. For example, there is scoring incisions, spreader grafts, septal cartilage or bone grafts, caudal septal repositioning in the form of caudal septoplasty, suture fixation to the anterior nasal spine, partial or complete replacement by septal or costal cartilage graft, and extracorporeal septoplasty. This picture shows the scoring incision. The scoring is partial incision in the axis perpendicular to the axis of curvature. If the curvature is cephalocaudal, we have to do partial incision in the anteroposterior direction. This is the conventional spreader grafts, two rectangular bar from the septal cartilage inserted on both sides of the septum after doing septoplasty. These different types of septal cartilage or bone grafts, this is from other publications. This picture from other publications. Caudal septal repositioning or caudal septoplasty, we have to excise the caudal overhang cartilage and mobilize the caudal septum to come in the midline. In spite of the above all these techniques, we have two main problems. First one is the weakening and the compromising of the middle vault and the nasal tip support. The second one is the recurrence risk of the recurrence risk is high due to cartilage memory, scar contracture, and collapse of the excessively weakened dorsal nasal dorsum. To overcome these two main problems, I did new design for the spreader grafts in the form of extended L-shaped spreader graft. This design addressed both dorsal and caudal septal deviation simultaneously. It preserves the keystone area and mobility of the nasal tip lobule. It provides support to the weakened dorsal and caudal septum without narrowing of the airway. This is a design. The red one is our extended L-shaped spreader graft. It extends from the keystone area dorsally and to the anterior nasal spine and maxillary crest caudally. And the blue one is the native cephalocaudal L strut after after scoring. This in our surgical technique, these are the instruments usually I use for implement my technique. Through the open approach, after injection of the ilocaine adrenaline, I expose the osteocartilaginous skeleton of the nose, and after that I deal with the dorsum. If there is hump, I will do a humpectomy or rasping. After that, I will approach the septum, dissect the septum from all extrinsic forces. And after that, I will come to the septoplasty. For my technique, I tackle the septum. I divide it into three portions. Caudal septum, middle septum, and the cephalic septum. I start by the caudal septoplasty, by dividing the connection of the septum around the anterior nasal spine, removing excess overhang cartilage, caudal and posterior, and scoring the twisted caudal strut. This is caudal septoplasty. This is the photo for caudal septoplasty. This is the excess cartilage, caudal and posterior. Then mobilize the septum in the midline. Proper septoplasty, all the cartilage in the central septum deformed, we have to excise, but I have to leave at least 1 centimeter dorsocaudal L strut for the future support of the nose. Straightening of the remaining cartilaginous septum by scoring the concave side in a plane perpendicular to the axis of curvature. This is the harvested septal cartilage graft. This is the remaining L-shaped strut. This X-ray CT scan for one of my patients. I want to stress one point: the cephalic septoplasty, usually missed by rhinoplasty surgeon. The osteocartilaginous junction of the septum we have to deal with, because if you are going to do osteotomy of the nasal bone and medial mobilization of the nasal bone, this area will prevent mobilization of the nasal bone, and this is the common cause of recurrence of deviation. This is the point I want to stress on it. Now I will come to carving our extended L-shaped spreader graft. It is fabricated as one piece. The dimension as follow: 1.5 to 2 millimeter thick, 4 millimeter width, and the dorsal part is usually 2 to 3 centimeters. Caudal part is usually around 2 centimeters in length. The connection angle was from 90 to 110 degrees. This is carving of the L-shaped spreader graft extended from the septal cartilage graft.
Dr. Ahmed, can we reach the conclusion, please? The time is out. Can we reach the conclusion, please?
This is carving from the costal cartilage from the 6th rib and the connection piece with the 7th ribs. This is insertion of the L-shaped extended graft. This is completion of the rhinoplasty. And we did 16 cases. 14 cases was excellent. Straight nose completely, and consistent with the examination and the post-operative photographs. Only there is 2 cases complaint of minor deviation. All the patient signed a medical photography consent. This is result of result of our technique. This patient has dorsal cartilaginous nasal deviation. This is front view, the post-op. This is profile view. This is basal view. This is another case with the deviated cartilaginous nasal dorsum. This is front view, post-op. This is profile view. This is bird's eye view. This is basal view. Another case with C deviation on the left side. This front view post-op. profile view, and this is basal view. This is, we can see the consistent nasal, complete nasal straight and well supported. This is another case. Another
Dr.
case
Ahmed,
with seizure
can we reach the
deviation on
conclusion,
the
please?
left side. This is front view, lateral profile view, basal view. The last case, this is also the same. This is basal view. This is the CT of this last patient. In conclusion, the extended L-shaped spreader graft act as independent support and stabilizer to the native L strut. It prevents recurrence over time. It lies cranial to the membranous septum, so there is free mobility of the tip lobule complex. Being one piece, it has intrinsic structural integrity. The dorsal component extends cephalically to the keystone area and the caudal part till the maxillary crest, and provide firm support to the weakened cephalocaudal strut. These advantages make the extended L-shaped spreader graft an excellent choice for severe cephalocaudal cartilaginous septal deviation. And if of the audience, if anybody interested in this technique, this is published in the BRS 2021. Thank you for your attention.
Thanks, Dr. Ahmed, for nice results. It's very good. It's my pleasure to introduce Dr. Munir Allam, who will talk about frequency of patients with hand infection presenting in King Abdullah Hospital in Bisha.
Can I start? Dear moderators, ladies and gentlemen, good afternoon and Assalamu alaikum. My name is Munir Alam, consultant, was 30 to 40 years, third most common 10 to 20 years, and the last group was the extreme of the age. About quarter of the patients in this study were male and 3/4 were females. And quite interesting to note, all of the 58 patients were right-handed in this study, as compared to the European study I've encountered. Approximately 1/4 to 1/3 of the patients are left-handed. That could be due to cultural difference. Approximately 50% patients in this study were Saudi national, the second most common Egyptians, and the third most common Sudanese and Pakistan, fourth place to India, and the last one Uganda, Indonesia, Morocco, and Yemen. The risk factors associated with the hand infection in this study were 4 types: diabetes mellitus, about 22%, similar number were smokers, and hypertension. In my opinion, hypertensive patients get infection due to bleeding, either they are on anticoagulants, aspirin, warfarin, clopidogrel, a trivial trauma, or maybe a prick lead to hematoma, bleedings, and with background history of diabetes mellitus, they get very easily hand infections. So all other patients we categorize into occupations. Related hand infection, the most common occupation in the study was 25% gardener and farmers. And the second most common, children and students. 15%, third most common, housewife and maids. And fourth most common, construction worker. And the third group was driver, shepherd, policeman. And the fourth group, painter, sweeper, cement factory worker, doctors, 1.7%. We categorize the diagnosis into 6 main groups of patients. The most common diagnosis in our study was subcutaneous infection, 41%. The second most diagnosis in our study, acute paronychia, 16.9%. The literature and the book shows is the most common diagnosis, acute paronychia, of approximately 40%. The third most common diagnosis in our study was web space infection, 15.4%. And the fourth most common pulp space infection, also known as phelone, 10.8%. In the literature and the book shows second most diagnosis is the pulp space infection, approximately 25%. The fifth category in our study was 9% flexitinosynovitis. Sixth category, 6% patient mid-palmar and thin arch hand infection. Microbiology associated with hand infection based on wound swab culture sensitivity. There was no wound swab was sent in 32% because there was wound close, or no in-situ drainage was performed. The most common organism we have found in our study based on wound swab for culture sensitivity, Staph aureus 27% and MRSA 20%, total of 48%. Literature shows 80% is a Staph aureus in hand infection. There was no growth in 8.6%. And the third group in our study was minority, Klebsiella, Proteus, and Serratia marcensis. The last group was combination of the organisms along with Klebsiella, could be Staph aureus, Enterobacter, or Serratia marcensis, 1.7% each. This is a chart showing microbiology. So we categorize the treatment modalities performed with the hand infection into 3 groups, either conservative, second in-situ drainage, and third amputation. Quarter of the patients were treated conservative, 69% in-situ drainage washout, and third group who had partial or total amputation due to osteomyelitis and septic arthritis with a background history of diabetes mellitus, all these 3 patients. Just overview of the hand function includes grip and grasp, pinch, expression, and sensation. Principle of treatment of hand infection includes rest and hand elevation. And to make early diagnosis, where indicated, start early ARV antibiotics and analgesia. And where indicated, in-situ drainage should be performed, and washout and debridement where indicated. And start early physio and occupational therapy to regain the normal hand functions. Just overview of the most common diagnosis. The first one, subcutaneous infection, which is the most common in our study, could be in the dorsal or volar aspect of the hand, most common in the manual worker where there is thick skin. It could be in the intraepidermal, intradermal, or subcutaneous, or could be in superficial and deep, known as Collerstad abscess. This is the infection on the thumb. It could be anywhere on the fingers, dorsal aspect, volar aspect, wrist, or forearm. You can appreciate ascending lymphangitis and cellulitis with the red streaks along the veins, which is a characteristic sign. With the lymphatic drainage for the ring and little finger goes to axilla, thumb and the index finger goes to axilla and the supraclavicular and neck nodes, and the middle finger infection goes to axilla. If the infection is not controlled or there are risk factors, especially diabetes mellitus, the infection can spread from the lymph nodes to systemic circulation, can lead on to septicemia. Second most diagnosis in our study was acute paronychia, most common in the literature, around the nail. This is the acute paronychia picture. Along with the pulp space infection, it should be differentiated with the viral infection known as herpetic whitlow, which should be treated with medical treatment. There's no in-situ drainage should be performed because the risk of systemic viral infection and encephalitis and death. The next web space infection, there are 3 triangular web space in the hand between the 4 fingers, and there's 1 web space between the thumb and the index finger. It can, most commonly it is on the volar aspect, but can point dorsally most commonly. Etiology is due to skin cracks, purulent blister, calostria through the lumbrical canals. Pulp space infection, also known as phelon, is the fourth most common in our study. Literature shows is the second most common. Could be through the pinprick and most common in the index finger and the thumb. The anatomically pulp space is divided into fibrous septa, and the digital vessels goes through this fibrous septa as end vessels supplying to the distal phalanx. It's quite dangerous infection to have the pulp space. Could be early diagnosed and treated early because the end vessel can lead to ischemic necrosis, slough, and infections. This is the pulp space infection. This is D-palmar abscess. In colored skin, sometimes it's very difficult to make diagnosis. It's a thinner abscess, very difficult to differentiate whether there is a full-blown abscess. We cannot appreciate lymphangitis or any streaks, redness. So on making an incision, the huge amount of thick creamy pus was drained, more than 20 ml.
2 minutes.
The next one.
2 minutes, please.
Okay. Acute suppurative tenosynovitis of the flexor sheath infection could be in the fingers or could be the thumb. There are 4 canal signs which help to make clinical diagnosis. Symmetric fusiform spindle-shaped enlargement of the finger, flex position of the finger, also known as hook sign, severe pain on finger extension, and tenderness on the volar aspect of the finger on palpation. So I go through the 3 cases which were diabetic and underwent for partial or total hand amputation. First case, DH, 81 years old male with uncontrolled diabetes mellitus for a long period of 15 years. Possibly he was treated by different specialties, orthopedic, general surgeon, presented to plastic surgery with amputation of the ring finger and necrotic area on the ulnar aspect of the hand. So we performed the amputation of the ulnar aspect of the hand along with the little finger. Well, wounds were slow to heal due to uncontrolled diabetes mellitus. And he developed carpal bone infection, septic arthritis of the wrist, and we planned for above wrist amputation along with orthopedic surgeons. So this is the above wrist amputation, left with forearm, elbow, with no hand. The second case, RN, 76 years old female, had background history of uncontrolled diabetes mellitus. And when she presented with a severe infection of the hand, we amputated the ulnar aspect of the hand. Later on, due to uncontrolled diabetes mellitus, you can appreciate infection of the carpal bone and septic arthritis around the wrist. We offered her hand amputation, but the family and herself refused for the amputation. Later on, she was admitted under care of medical teams for multiple organ involvement due to diabetes mellitus, and the axillary lymph nodes were involved. Hand was slow to heal. She was rest in peace under care of medical team due to multiple organ failure. Third case was female.
Conclude,
Just the last case. 46 years, male diabetic, 17 years, had a chronic renal failure on dialysis. Debridement was performed for the middle finger. Developed osteomyelitis and septic arthritis. Amputation was performed. This is the final picture. To summarize my presentation, it's important to make early clinical diagnosis based on occupational history and risk factors such as diabetes mellitus and smoking is effective in the prevention and treatment of hand infection to avoid grave complication and disastrous surgical intervention of partial or total hand amputation. Thank you for paying attention.
Thank you, Doctor. Time for invite Dr. Obaid Al-Asadi, etiology of trauma-related acute compartmental syndrome of the hand, systemic review.
Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Obed Saadi, a surface plastic resident at King Fahd Hospital in Al Madinah Munawwara. I'm very glad to be here in front of you presenting this research. And I'm really thankful for Dr. Ziad and this committee for giving us this beautiful chance to be here. Our research talk about the etiology of trauma-related acute compartment syndrome of the hand, a systematic review study. I want to thank all my colleagues and my team for helping me doing this research, especially our mentor, Dr. Basim Al-Husseini. I'm going to take 5 to 7 minutes, inshallah. Okay, this is our objective for today's. We'll talk about the introduction, methodology, result, discussion, and the limitation and the conclusion of our study. Okay, let's start by talking in general about acute compartment syndrome of the hand. Acute compartment syndrome, known as elevated pressure within the enclosed compartment that lead eventually to impaired blood supply and decreased circulation, leading to edema, muscle necrosis, nerve injury, and arterial injury. It's caused by trauma and non-trauma causes, so we specify the trauma causes in our study. In general, the most common causes of acute compartment syndrome was the anterior compartment of the leg, followed by the forearm compartment. In the upper extremity, we have 5. We have the shoulder compartment, forearm, and arm, and also some author involve the wrist with the hand, and some author are not. In our study, we separate the wrist from the hand. As all we know, there is a cardinal 5 Ps for acute compartment syndrome: pain, paralysis, paresthesia, pulselessness, and finally paralysis. In the hand, there is a specific situation. As we know, we have a 10 compartment in the hand: 4 dorsal interossei, 3 volar interossei, adductor and thenar and hypothenar. We have no nerve ending in the hand compartment syndrome, so it's going to be 4 instead of 5 Ps, so there will be no nerve deficit. Okay, hence it's quite difficult to diagnose hand compartment syndrome in contrast to other area. And although there is no previous systematic review discussing the acute traumatic causes, there is one study, systematic review, talking in detail about non-traumatic causes. Okay, so we start with our method. We follow the PRISMA, which is a guideline for systematic review with a multiple checklist. We search among midline and EBSCO database using a specific keyword. 8 author was carried out eligible screening for the title and the abstract. Then full text assessment and data extraction done. Finally, if there is any disagreement between 2 authors, the discussion or the decision will be by a 3rd author. Okay, this is the PRISMA flow chart as shown on the slide. Okay, we have 1,085 articles. After title screening, after abstract screening, the final number was 157 articles. After applying our inclusion and exclusion criteria, the remaining was 29 articles only. This is our inclusion and exclusion criteria. We include any data containing traumatic causes of acute compartment syndrome. 18-year-old was included. Availability of the full text. Study published between January 1950 and April 2022. RCT case control, cohort study, all was included. The exclusion criteria was chronic causes, iatrogenic causes, and pathological cause of compartment syndrome. And article in language other than English was excluded also. Our result, as we mentioned before, 29 article was included, with 129 patients constituted the basis of this review. We classify the etiology of hand compartment syndrome into 3 classes: fracture-related, soft tissue-related, and vascular-related. Okay, this is a table summarizes the causes of the soft tissue-related acute compartment syndrome. As we can see, the burn was the most common cause with 71 patients in total number of 113. Constitutive, the percentage was 62.8, followed by there is not reported soft tissue injury, animal bite, and crush hand. The fracture-related in this study was the second most common, followed by the soft tissue. In contrast to the forearm and the leg, which was the fracture-related, was the most common cause. We have the first metacarpal bone, second and third and fourth metacarpal bone fracture was the most common causes. Here we prefer to look to the cases number rather than the percentage because of the low number of fracture-related and also the vascular-related. We only have 2 cases. One for brachial artery and one for ulnar artery that lead to acute hand compartment syndrome. The result, the diagnosis of acute compartment syndrome based on clinical finding, and they use sometime intracompartmental pressure measuring in 46 cases. 45 cases diagnosed based on clinical finding only, and the remaining didn't specify the method of the diagnosis. In total, 129 patients, and relieved that the most common etiology was related to the soft tissue injury, with burn being the most common cause. Fracture were the second most common cause, and followed by the vascular injury. As we mentioned, we prefer to look to the number of cases rather than the percentage. Our limitation, high number of included case reports and case series. We are unable to obtain a holistic view regarding the different treatment method option, and low number in certain etiology like fracture and vascular related. Therefore, looking at the number, the percentage. Conclusion, identifying the most prevalent cause can help in early detection of acute compartment syndrome by frequent assessment of the patient, especially in the burn as it constitutes the most common cause. This review was conducted to increase the knowledge for treating physicians regarding the various traumatic etiology of the hand in the literature. Intra-compartmental measurement is required to diagnose intubated or obtunded patient, as well as patients who are under sedation, and also for our children. This is our references and the full text. And thank you for your listening.
Thank you very much.
Thank you so much. Thank you for all the speakers. Now, I think Dr. Ziad has an announcement.
Thank you, Prof. Sabah. Thank you, Dr. Faris and Dr. Muhammad and Dr. Sharif. Actually, we are coming to a tricky part after this break, which will be a workshop. So actually, we have concluded our conference, and the workshop here will be intended for residents and for students. It's about burn care and wound care. It will be here after the break. So we will take like 10 minutes to 15 minutes a break. And then I urge all students, all interns, all residents, even junior specialists to stay here to get the most advanced techniques in burn and wound care workshop, which will be held by our speakers, most of them local faculty with Professor Hans Oliver Rennekamp. During the same time, I would like to ask our international speakers, Professor Norbert Palua, Professor Piccolo, Professor Amin Kalaji, including me and Professor Sabah, all of the brass speakers, to go into another room. We will have coffee together, and we will discuss more about liposuction, processing, and fat grafting techniques. We will give space for discussion. It will be a forum of discussion until